Okay, Mr. Chairman and members of the subcommittee, I first want to thank you for giving me the opportunity to speak today. Since AIDS was first recognized in 1981, over 14,000 cases have been reported to the CDC. Because AIDS is such a serious disease and affects a relatively young population, its potential economic impact is great. My coworkers and I have developed estimates of certain aspects of this impact for the first 10,000 reported cases of AIDS in the United States. These estimates include estimates for expenditures of hospitalization and estimates of resources lost due to disability and premature mortality. First, let me point out that the data available to make the necessary calculations for these estimates were limited and often based on small samples of patients, but they represent the best and often the only data that could be obtained. These data were extrapolated to the 10,000 patients to get national cost estimates. Because of these limitations, the cost figures should be viewed with a certain amount of caution and are best used as broad estimates. Hospitalization expenditures were calculated by multiplying the estimated total number of hospital days for the 10,000 cases by the estimated average daily hospital charge for AIDS patients. Data available to determine total hospital days included the average length of hospital stay for AIDS patients, which was available from 3 surveys, one done in San Francisco, one done in the municipal hospitals in New York City, and one done in Philadelphia. This figure was used to estimate the duration of the first hospitalization for AIDS. To estimate rehospitalizations, we used the percentage of time hospitalized after the initial hospital stay from a study published by the New York City Health Department. For the purpose of our calculations, we used a median survival from AIDS diagnosis of 56 weeks. We estimated that the 10,000 AIDS patients would require approximately 1,678,000 hospital days. Again, let me point out that since the data used to arrive at this estimate involved hospitalizations that occurred between 1981 and 1984, we urge caution in projecting lengths of hospital stay for future patients. To estimate expenditures for hospital care of AIDS patients, the hospital days were multiplied by $878, which was the average daily charge for AIDS patients admitted to an acute care hospital in Atlanta. The result was an estimated $1.47 billion in expenditures for hospitalization. In addition to the cost for health care, there are indirect costs from work loss from disability and premature mortality of AIDS patients. Based on data collected by the New York City Health Department, we assumed that 86% of all AIDS patients would be unable to work from diagnosis until death, and that these patients would lose approximately 8,000 years of work due to disability at a cost of almost $189 million in lost earnings. The cost of premature death due to AIDS was calculated assuming all 10,000 patients would die prematurely from the disease. Using standard tables for potential future income by age at death, the economic loss in 1985 dollars from future earnings lost following the premature death of these 10,000 patients was calculated to be $4.68 billion. To express our findings in another way, we estimated that the average AIDS patient will be hospitalized for 168 days before eventually dying, with resulting expenditures totaling $147,000 per patient. Each patient will also lose an estimated 10 months of potential working time and $19,000 in income due to disability. The loss per patient death in terms of future income is $470,000. Again, the figures that I have presented are estimates, since relevant data was available from only a few sources. For individual patients, costs will vary depending on a variety of factors, including the opportunistic diseases, the duration and frequency of hospitalization, and the geographic location of the patient. As more detailed information relevant to costs is collected, improvements can be made in the cost estimates. CDC has recently contracted to determine the economic and financial implications of AIDS nationally, including the impact of recommendations for the prevention and control of AIDS. Our estimate of $147,000 for the hospital care of each AIDS patient may be high in part because data on hospitalization after initial stay was available only from New York City, and hospital usage by AIDS patients there may be greater than by patients in other areas. It is important to note that there is potential for these expenditures to be reduced somewhat through means such as the development of more effective drugs to treat the opportunistic diseases and increased availability of out-of-hospital care. Also, I should mention that other important health care expenditures, such as home medical care and outpatient care, could not be estimated due to lack of data.
Dr. Hardy, you think then that there's some chance that we can decrease the cost for care as we move to other health care settings, is that right?
I think that's a possibility, yes. Obviously, if you reduce the number of in-hospital days, you would reduce the associated costs.
Mm-hmm. Well, your study covered the first 10,000 AIDS patients in the United States, and that covered a period of 4 years. As you think about the next 10,000 patients who will be diagnosed before next summer, how expensive do you think it will be to care for them? And let me pose that in this way. As healthcare institutions become more familiar with hospices and outpatient care settings, do you think the costs will go down? On the other hand, because people will be living longer, yet not being cured, do you think the costs will be going up?
I think both of those are possible. I think it's difficult to predict from this data because I think this field is changing. Patient management practices are changing and availability of out-of-hospital care is changing, that it's difficult to predict from what I've done how to apply these figures to the next set of 10,000 cases.
There seems to be a great disparity in the cost for treatment of a patient in one location as opposed to another. For example, in New York, it's much more expensive for treatment of AIDS patients than it is the case in San Francisco. Why is that?
I think there are probably several different reasons. One, the distribution of patients into risk groups differs somewhat by geographic location, and one of the determinants of what opportunistic diseases patients have is their risk group. For example, gay men are much more likely to have Kaposi sarcoma, and the IV drug users are much more likely to have other opportunistic infections. And I think the disease that you have will in large part determine hospital expenditures. Also, I think...
Is it more expensive to treat an IV drug abuser who develops AIDS as opposed to a male homosexual who develops AIDS?
I think, again, it may depend in part on what disease they have. I would think Kaposi sarcoma, at least initially, is less often acutely life-threatening and may not, there really isn't data broken down by disease group, but it may not, that patients with Kaposi sarcoma may not require as much hospitalization or expensive drug treatment as someone with say, pneumocystis pneumonia. They may not require intensive care treatment.
So we think of AIDS, we think of treating AIDS, but are we treating AIDS or are we treating the diseases that people get because they have AIDS?
Treating the diseases that they get because they have AIDS.
AIDS means their body can't fight off these infections like Kaposi sarcoma, which is a cancer.
AIDS is the term that is given to the most serious clinical manifestation of infection with the AIDS virus, which is termed HTLV-3. Mm-hmm. As with many viral diseases, there's a whole spectrum of response, clinical response to that infection. AIDS is the most serious form of the disease. People with that form, with AIDS, their immune system is broken down to the point that they are susceptible to and develop these other opportunistic diseases and cancers.
Now, you point out that the length of stay and the cost for AIDS patients in San Francisco is significantly less than other cities. Why?
Again, I think it may relate to the diseases that the patients have there. About a third of the patients in San Francisco have Kaposi sarcoma. Also, there are probably different patient management practices which would could account for some differences, and possibly differences in availability of alternative non-hospital-based care.
So you say different patient practices and alternative care. Is that the same thing? Does that mean hospices and home health care, outpatient
I guess
care?
by patient management practices, I'm talking about practices within the hospital.
I see.
They may be more aggressive in getting the patient out of the hospital earlier or in treating them, in not putting them in the intensive care unit and things like that, which might reduce costs.
And do you think that the model of San Francisco's healthcare system, which seems to be less expensive, might be used by New York and other places for their patients?
I think every location probably has to develop a system that works for the type of patients that they have.
Yet, insofar as these patients are covered by federally funded healthcare systems such as Medicaid, we may be paying twice as much for an AIDS patient in one location as opposed to another. Is there anything the federal government might do to try to encourage the holding down of the cost for the care of these patients?
I'm not sure I'm really the appropriate person to respond to that. Again, I think each individual area has to make a determination on what is best for their patients.
Well, thank you very much. Mr. Madigan?
Dr. Hardy, let me read you a sentence from a staff memorandum, and then I want to ask you if you agree with this. This sentence says that part of the problem is that because AIDS includes several illnesses resulting from a deficiency in the immune system that are not being designated in medical records as AIDS, the actual number of victims in a population may be understated. Would you tend to agree with that or disagree with that?
I think it's possible that there are cases of AIDS, cases that would meet our CDC surveillance case definition for AIDS that are not being reported. However, we have several ways to try and address this. CDC used to be, up until recently, was the only source of pentamidine, a drug which is used to treat pneumocystis. So we were able to review requests for this and try to find out about cases that perhaps had slipped through the reporting systems. Many health departments are using death certificates, reviewing death certificates, hospital discharges, and other record systems to try and find out about cases that may have not been reported. A study was done in New York City back in 1983 and 84, where they actually used some other record systems to see if they could find out about AIDS cases that had not been reported, and they found out that well over 90% of the cases had been reported through their reporting system. So we feel reporting is quite good for this disease.
As a member of this subcommittee now for some years, I've been extremely interested in this and have read everything that has come to my attention on this subject, and am still very confused about the means in which it may be communicated. Last week I read that in the Pasteur Institute in Paris, a scientist had isolated the virus, placed it in a dish, left it there for 7 days, then added water and white blood cells, and the virus became active. Are you familiar with that?
No, I'm not.
Let me ask you if it would be possible, in your judgment, if a person with an open sore on a buttock were to go into a sauna or steam room and sit where an AIDS patient had previously been sitting, would there be any possibility of that person acquiring this illness?
Well, first, I would think that AIDS patient would have had, there are very few body fluids that I'm aware of from which the virus has been isolated. I don't think sweat is one of them. Theoretically, I suppose it's possible. I think it would be very unlikely.
Well, we've heard this morning, we hear that it is very hard to communicate this virus. And then we've heard this morning that in Los Angeles and New York City alone, there are almost 600,000 people that now have the virus. It must not be too difficult to communicate it if 600,000 people in 2 cities in the United States have it. I am at a loss to understand, but to be very graphic with you, I can understand how it is spread from a man to a man, and I can understand how it is spread from a man to a woman. But I'm at a loss to understand how it is spread from a woman to a man. Can you explain that to me?
I can give you some theories on that. I'm not sure I can give you the exact evidence. We do presume, based on data in the United States and data in countries where heterosexual cases account for the large majority, that it can be spread from women to men. I think studies are underway to determine whether the virus is present in vaginal secretions. That hasn't been determined, but that is one possibility. It is also possible, but not yet determined, that the virus may be present in menstrual blood.
Some 5% of the...
Gentlemen, yield to me.
Yes.
Yeah, obviously, on all our minds and the minds of the American people is how is this thing spread? How likely are we to get AIDS? We've had some hearings on that, and we're going to have other hearings on it. We have to do whatever is going to be necessary to try to stop the spread of this disease. This is a statistician from the Center for Disease Control. The other witnesses were hospital administrators. We are looking specifically at this hearing on the cost for care, but we will hold other hearings and get these answers again as we review the spread of the disease. I don't want to interrupt your questions, but I just want you to know that a statistician may not be the best person to ask these questions of from the Center for Disease Control, and we will have hearings where we'll have other experts that may be better able to answer.
Well, all right, I stand properly rebuked since the red light is on anyway. But I do think, as I said in the earlier exchanges, Mr. Chairman, that if we want to deal seriously with this, and I know we all want to do that, then we clearly have to do a much better job of public education about how this virus is being spread. And I think there's a lot of confusion about that in the public mind today, and there is in my mind, and I've been on this subcommittee since this issue started. I was, you may recall, instrumental in helping you get the very first increase in funds for AIDS research back some now 4 years ago. I continue to be interested in it, continue to be confused about it, and acknowledge that my time has expired.
Well, let me, well, your time has expired and we're going to have to break to respond to a vote on the House floor. Let me say that we will schedule as soon as possible a hearing on that subject. I know Mr. Dannemar has introduced legislation recently on that area, and others continue to ask questions. We'll hold another hearing and bring the experts in and review what we know, what the theories are, so that we can educate ourselves and continue to educate the American people. We're going to break now just so long as it'll take to respond to the vote on the House floor, and then we'll come back, and Mr. Dannemar will be recognized at that time.
Mr. Chairman?
Yes, Mr. Shore.
Just to emphasize the remark that our ranking minority member made as to the degree of confusion here, we heard two professionals in the preceding panel absolutely contradicting each other as to whether it was appropriate for a dentist with AIDS to treat patients. You can't imagine a more dramatic example of the medical profession that hasn't gotten its act together on what it would advise 240 million American people out there.
If you'll permit, those weren't experts to tell us about the spread of the disease. Those are hospital administrators to tell us how much it costs a hospital to treat the patients that are in that hospital when they are treated for AIDS or the related illnesses. We're going to recess now for 5 minutes.
Let me point out to my chairman, they're human beings concerned about the fear.
Will come to order. Mr. Dannemar, do you wish to question this witness?
Yes, I do, Mr. Chairman. Is it true that the ELISA test is used as part of the CDC case definition for AIDS?
For certain diseases, yes. We have just changed the case definition recently to include certain diseases if the person also has a positive HTLV3 test.
Is it used for AIDS?
A positive HTLV3 test by itself does not indicate whether or not you have AIDS. It just indicates whether you've been in.
Is it true that the ELISA test is used as part of the CDC case definition for AIDS?
Okay, we have recently changed our case definition to include some additional opportunistic diseases that we consider to be indicative of AIDS if the person also has a positive HTLV3 test.
Well,
so you have to have both. You have to have one of those diseases and a positive antibody test.
Is the CDC recommending that the ELISA test be used to detect the presence of AIDS?
The test cannot tell whether you have AIDS. It can only tell whether you have been exposed to the virus that causes AIDS.
Isn't ELISA the only diagnostic medical tool for determining the presence of the virus?
I'm sorry, I didn't hear the only what?
Isn't ELISA the only diagnostic medical tool for determining the presence of the virus?
There's also virus isolation or culture for the presence of the virus itself, which is more of a research tool, but which can also be used to detect the presence of the virus. The ELISA test does not detect presence of the virus. It detects presence of antibodies, which the body makes in response to the virus. It does not tell you whether the virus is still present.
Would you not conclude that a positive ELISA test is pertinent medical information for determining the presence of the AIDS virus?
Gentleman yield, this is a statistician from the Center for Disease Control. I don't know if she has it within her competence to answer those questions. She's here to tell us about the number of AIDS cases, the cost for care, the predictions as to how the cost may go up or down depending on various modalities of service and circumstances.
Mr. Chairman, if the witness doesn't know, I think she can say she doesn't know.
Right. I feel I'm not the appropriate person to respond to that.
Is CDC pursuing any means of increasing the reportability of AIDS?
I think we have been working for several years with state and local health departments to develop ways for them to establish surveillance systems to get cases. Cases are reported to us through local and state health departments.
If a physician encounters a case of AIDS in his practice in my state of California today, is that physician required to report the existence of the AIDS case to the State Department?
It would depend on the state laws, and I'm not. Many of the states have laws regarding AIDS reporting. I'm not sure of which specific ones, and I don't know about California.
Is there any requirement today that under CDC that AIDS-related complex ARC be reported?
CDC cannot mandate even that AIDS be reported, and the only health district that I'm aware of that has made ARC reportable is the city of Philadelphia. But we do not ask that such cases be reported to us.
As of August of this year, it was the policy of blood banks to mandate that persons in a certain high-risk group, intravenous drug users who contribute 17% of AIDS cases, cannot donate blood. At the same time, it was the policy that persons in the group that contributes 73% of AIDS cases who claim to be polygamous male homosexuals could not donate blood, or should not donate blood, rather. In August of this year, it was still a policy that those male homosexuals who claim to be monogamous, there was no restriction on them donating any blood at all. In September, I wrote a letter to HHS requesting a change in policy to put all male homosexuals in the same category as intravenous drug users in the cannot category. On September the 8th of this year, CDC, in response to something, wrote a letter changing the policy whereby all male homosexuals were put in the should not category. That's the status today. We're in the picture today where persons in the group contributing 17% of AIDS cases, intravenous drug users, cannot donate blood. But persons contributing 73% of the AIDS cases are in the should not category. Now, don't you think that paradox should be corrected? Don't you think that persons in the category contributing 73% of the AIDS cases should be in the cannot donate category?
Okay, I think the wording has been changed so that men who have had sex with other men, I don't even think it uses the term homosexual because that may be misleading to some people, should not donate blood. I really don't know what the wording was beforehand, and I can't comment on that.
The gentleman's time has expired. Mr. Scheuer?
Yes, I would like to get back to the question of the economics of this disease and how we can lessen the burden on the tax holder and perhaps even increase the quality of the care, at least from the humanitarian and compassionate point of view. You were asked by our ranking minority member a few minutes ago before the break why San Francisco seemed to be able to treat AIDS patients less expensively than New York and other cities. And you gave what to me was a little bit of a somewhat ambiguous answer. Could you repeat that answer?
Yes, I think there are several possibilities. I can't give you an exact explanation of why these differences exist. I think there are several possibilities, including the type of opportunistic diseases that the patients have. In San Francisco, about a third of them will have Kaposi sarcoma, while in New York City, since they have a much larger proportion of cases who are IV drug users, they will have a larger proportion with other more serious opportunistic infections such as pneumocystis pneumonia. And I think this may influence length of stay and expenditures while in the hospital. Also, I think there may be differences in patient management practices that will influence this, such as differences in putting or not putting patients in intensive care.
For the same treatment, for the same...
Yes, I think there are differences.
Sickness?
Again, I can't give you specifics, but there may be differences. And differences in availability of non-hospital care, such as home care, hospice care, long-term care, things like that.
Right. Well, I think we will all encourage New York City to get on with the business of developing alternatives to intensive treatment in tertiary hospital beds, which is the most expensive form of hospital care and which apparently is not really needed in many of these cases for much of the time that they're being treated. It seems pretty clear that for much of the time that these AIDS patients are being treated, a hospice environment or a home care environment is adequate. In fact, is not only far less expensive, but may be preferable. Can you give us a little bit more of the patient management practices that might differ? Could you give us specific examples of the kind of patient management practices for the same disease, the same strain of the virus, that would make treatment more expensive in New York or Hartford, Connecticut, or St. Louis or Philadelphia, and less expensive in San Francisco? In other words, has San Francisco got the germ of an idea that might usefully be applied in the rest of the country?
I think people from San Francisco would probably be better to answer this than me. I don't really have specifics to give you. These are just what I feel are possibilities to explain these differences.
All right. Thank you very much.
Thank you, Mr. Scheuer. Mr. Lucan, any questions? No. Thank you very much, Dr. Hardy, for your testimony. We appreciate your contribution to this hearing. For our next group, we would like to call forward a panel, Ms. Mary Nell Lenhart, Vice President for Office of Government Relations, Blue Cross and Blue Shield Association of America, Dr. Donald Chambers, Vice President and Medical Director, Lincoln National Insurance, on behalf of the Health Insurance Association of America, and Mr. Willis Goldbeck, President, Washington Business Group on Health. We will come back to the remaining panels, but we had to make this scheduling change. Well, we're pleased to welcome the three of you to our hearing. Again, as you know, the ground rules are to summarize your testimony in 5 minutes, and we'll make your full written statement part of the record. Ms. Lenhart.
Mr. Chairman and members of the committee, I'm Mary Nell Lenhart, Vice President of Government Relations for Blue Cross and Blue Shield Association. I'm here representing all the individual Blue Cross and Blue Shield plans. We appreciate this opportunity to testify, and I'd be pleased to submit our statement for the record and summarize our comments. Since you've heard from a number of experts on different aspects of AIDS, I'll move right to the perspective of the health insurance industry. It reflects the fact that the ability to continue to provide coverage for all subscribers requires continued financial solvency. That solvency depends in part on the ability to accurately project the cost and utilization of health insurance benefits and to limit or control the impact of catastrophic losses. The nature of AIDS and its potential for afflicting unknown numbers of persons makes such projections difficult for us. The lack of comprehensive and accurate information on AIDS and the financial uncertainties pose special problems for the health insurance community. One of the questions this committee is interested in is whether, because of the very high costs of the medical treatment involved here, is whether health insurers are using special screens or tests to exclude those diagnosed as having AIDS. We do not believe that any Blue Cross and Blue Shield plans are treating AIDS victims any differently than any other individuals who have Blue Cross and Blue Shield coverage or want to enroll in our coverage. We know of no case where a plan is using a blood test to identify individuals who have contracted the virus, and we know of no case where questions are asked about lifestyle in an attempt to identify a vulnerable individual. Whether an individual has AIDS or really any other disease is not a factor in the availability of benefits under Blue Cross and Blue Shield coverage for employee groups of medium to large size. No individual in these groups is treated differently regardless of any medical condition they have, and there's really no reason for their employer to know what conditions they have. I might mention that we are aware of one instance in California where an employer insisted on excluding benefits for sexually transmitted diseases, including AIDS. The plan there involved was concerned about adding such an exclusion to their contract, particularly without the knowledge and consent of the insurance department. When the group threatened to self-insure, thus avoiding any kind of state regulation, the plan applied for approval of this particular exclusion. After reviewing the application, the insurance department advised the plan that it was not authorized to design benefit contracts which exclude sexually transmitted diseases. However, this particular plan continues to be concerned that this employer and possibly others will turn to self-insurance, as many employers are doing now, to avoid such state regulation. All Blue Cross and Blue Shield plans also offer coverage to small groups and individuals. These segments of the markets represent a much greater risk for us financially because of the higher administrative costs and, very importantly, the potential for adverse selection. Adverse selection occurs when a group of insured individuals has a higher concentration of those who have medical conditions than a competing group. As soon as the insurer sets a premium adequate to cover those medical expenses, those individuals who are healthier will tend to leave and seek coverage in groups with better risks and, on average, lower premiums. This movement of the better risk serves to further increase the concentration of the poor risks, which in turn causes premiums to increase, thus driving out some of the better risks once again. This cycle of adverse selection, if not controlled, can spiral to the point that insurance isn't able to price that group in such a way as to be competitive in the marketplace. Now, health insurers can protect themselves from enrolling high-risk subscribers in individual and small groups and starting this spiral of adverse selection by excluding those who already have medical problems or limiting coverage for those conditions. Blue Cross and Blue Shield plans, however, accept small groups with very little or generally no underwriting to exclude the worst risks. Many Blue Cross and Blue Shield plans will take individuals who have already developed medical conditions either any time during the year or during an open enrollment period. I might say that the unpredictability of AIDS and its potential financial consequences, it will make this much more difficult for plans to do in the future. There may be a waiting period for these individuals at the time of enrollment. This is necessary to discourage people from waiting until the last minute till they're actually sick. But after that, the conditions are covered in full. In conclusion, we know of no cases where Blue Cross and Blue Shield plans currently treat subscribers or potential subscribers any differently than anybody else with any other medical condition.
Thank you very much. Dr. Chambers, could you be sure the mic is on?
Mr. Chairman, I am Donald C. Chambers, MD, Vice President and Chief Medical Director of the Lincoln National Life Insurance Company, which is headquartered in Fort Wayne, Indiana. I appear before this subcommittee today on behalf of the Health Insurance Association of America. The HIAA is a national nonprofit trade association comprised of 335 companies that represent approximately 85% of the private health insurance currently sold in this country. The insurance industry is very much concerned about the AIDS crisis. Representing the health arm of the insurance industry, the HIAA is grateful for the opportunity to share with you today our views and concerns in regard to AIDS, particularly as they relate to health care costs and financing. I would like to begin my remarks by briefly commenting on the cost of treating today's patient who has AIDS. Very little data seems to have been reported in this regard. The Centers for Disease Control has said that costs may be as high as $147,000. My company has identified some 40 group medical expense cases, and of the 13 claimants who eventually died, total claims costs have averaged $60,000. I must add that insurance companies find it very difficult to compile such data. In many instances, an insurance claims examiner can only assume that a case is an AIDS case, since the word AIDS is generally not mentioned. Even on death certificates, it seems that doctors are reluctant to list AIDS as an underlying cause of death. Despite these limitations, the Health Insurance Association of America will soon be attempting to survey its member companies to determine the cost of AIDS-related claims. The HIAA would, of course, be happy to furnish this subcommittee with survey results. Inpatient hospital costs, as you well know, are only a part of overall costs for caring for AIDS patients. Insurance companies, through large case management programs, are exploring attractive alternative care cost-saving opportunities such as home health care. Lincoln National is one such company. Whatever the health care costs are today, we know that they will climb rapidly in the next few years because of the rapid rise in cases. Given that at last count, some 160 million Americans under age 65 were covered by some form of group health insurance, and millions more by individual health insurance, the health insurance industry is well aware of the liabilities that it faces, and we are fully prepared to pay all age-related claims under the terms of our contracts, just as we pay claims for all other medical conditions. We do have a fiduciary relationship with our policyholders, meaning, among other things, that we are pledged to set premium rates at a level that is consistent with the evaluation of risk for that client. About 85% of insureds in this country are covered by group insurance. These people are not individually underwritten, but rather the underwriting process applies to the group as a whole. Individual insurance, on the other hand, does involve individual underwriting, i.e. selection and classification of risk. All relevant health-related information is evaluated by the underwriters, and an assessment of risk is made. Applicants are then asked to pay a premium that reflects their level of risk. While on this matter of fairness and the underwriting process, let me say that current legislative trends threaten to jeopardize the underwriting process by denying insurance companies the right to order and/or use antibody test results. The insurance industry believes that a repeat reactive ELISA test followed by a positive Western blot test does indeed provide an underwriter with a reliable indicator of significantly increased risk. But California and Wisconsin have passed laws forbidding insurance companies from using antibody tests to determine insurability. This unprecedented denial severely limits our ability to do a fair and equitable job of risk evaluation. This marks an unprecedented departure from an insurer's traditional ability to underwrite with access to all pertinent medical information. Legislation of this type fosters adverse selection and can be expected to result in subsidization of a high-risk group by the low-risk population. A word about confidentiality of test result data possessed by blood banks, plasma centers, and alternative test sites. The insurance industry understands the necessity of maintaining public confidence in our nation's blood banking system. We have pledged not to attempt to access this data. Another pledge that we make deals with the matter of maintaining confidentiality of age-related information, including antibody test data information. Insurance companies have a long and accomplished track record of dealing with highly sensitive medical information dealing with such things as chemical dependency, alcoholism, syphilis, etc. Age-related data will be protected in an equally secure fashion. The life and health insurance industry fully supports the Model Privacy Protection Act adopted by the National Association of Insurance Commissioners, and which addresses the consumer's need for confidentiality. Mr. Chairman, let me assure you that as an industry, we acknowledge a legitimate responsibility to bear our full share of costs related to this epidemic among those that we already cover, and with proper safeguards among those who will seek and obtain our coverage in the future. As my testimony has shown, we expect that AIDS will is having a profound impact on the health insurance industry. It is clear, however, Mr. Chairman, that the risks undertaken by health insurers can only properly represent the interests of premium-paying policyholders if our industry is not impeded by prohibition against time-honored underwriting tools. This epidemic has implications which go far beyond our capacity.
Will the witness please sum up?
Okay.
Thank you.
In closing, let me repeat that I feel privileged to have had the opportunity to share my thoughts and comments with this committee. I hope that my testimony will prove to have value. The HIAA stands ready to further serve this health and the environment subcommittee in any way that we can.
Now we'll hear from Mr. Willis Goldbeck, President of the Washington Business Group on Health. Mr. Goldbeck, if you would take around 5 minutes and perhaps not read your testimony, just speak with us informally as if you and we were in a living room together. Then we'll have some time to ask you all some questions.
Would be my
Please
pleasure.
proceed.
Thank you. We are also pleased to be here today. This is a problem that affects every employer in the United States. And I hope our small statement and our policy position at this time will be a message not only from the members of the business group, but a message to employers nationally. Employers should treat the illness of AIDS and the related illnesses precisely as they do every other illness for which they provide medical and health insurance. There is neither justification in epidemiology, insurance, or social policy for treating AIDS in some distinct fashion from the standpoint of medical and health benefits. The same confidentiality rules should apply as do elsewhere. The disease should not be subject to exclusion. And to the extent that insurance carriers are pressured by employers who are attempting to shirk their responsibilities, we hope that those insurance carriers will stand strong and resolute and recognize that the vast majority of employers will not make such requests. The AIDS, as we have heard earlier, is not only a disease, it is in fact a process by which a great many other diseases come to the individual victim. All of those diseases are now covered by medical and health insurance. None need be excluded now because of the presence of this new causal factor. Some health insurance plans have pre-existing clauses. If one has AIDS prior to application for job and insurance, potentially that clause could be applied. But it should not be created for the purpose of AIDS, only applied if it is applied in equal fashion to other illnesses. Certainly this is an expensive illness, but so too are the $35,000 to $80,000 costs of neonatal births. So too is the greater than $100,000 average cost of leukemia and the $250,000 average cost of liver transplants, and those are not even for employees in most cases. And we pay those today, as well we should. Most employers have been responsible. And I know that you have expressed an interest in the case management approach that was described. It does appear that not only in the public sector patients in their hospital care, but in the private sector patients and employers in California, through employer plans in California, are experiencing dramatically reduced costs on a comparative basis because of the style with which they deal with this problem, the degree to which they use hospice care, the degree to which they use individual case management programs. That means they recognize the need for social services within the context of health, not just medical care for a disease entity. It means appropriate home care. It means not driving patients into teaching hospitals when there's nothing to be taught. It means a job accommodation programs where that's appropriate, so that those who have the illness can be treated with the same rehabilitation programs that have proven to be true for other people with other illnesses and injuries. It means establishing prevention education programs, a resource center for communications to establish that the individuals understand the corporate policy, understand their benefits are protected, understand the problems that are attendant with the disease, training for managers and supervisors, establishing corporate-wide task forces that bring together the various communications, medical, health, insurance, legal entities within the corporation that have responsibility for dealing with all the aspects of this issue, which go way beyond just the topic of today's hearing. So yes, we feel very strongly that AIDS is an illness. It is not a crime. It is not a punishment, nor should it be treated as one. It is not limited by or to any sex or age or racial or economic or class cohort. So described, AIDS sounds remarkably like cancers, alcoholism, hypertension, cardiovascular diseases, other lifestyle-related diseases, none of which we design special policies to institutionalize blaming the victim. By urging employers not to overreact, we are not pretending that AIDS is not a serious issue. We believe very strongly that the private and public sector must work together on this issue, that it is certainly national in scope. And we have been encouraged that many of our members have been willing to invest in treatment, not in retribution, in education, not exclusion. And that should be the policy that employers articulate and conduct around this country. Thank you very much, sir.
Thank you, Mr. Goldbeck. Let me start the questioning of Dr. Chambers. As I understand your testimony, you would advocate the screening of applicants for health insurance with the blood test, and if they had HTLV3 positive, your companies would not insure that individual. Is that correct?
The insurance industry would like to have the privilege of using the antibody test because we feel it would give us the opportunity to do a more objective way of detecting who those people are who have been infected with the virus. We're interested in ensuring everyone, the vast majority of people in this country who have not been infected with the virus, but we feel those who have been infected cannot qualify for life or health insurance on an individual policy basis. Doesn't apply to group covered people.
So this would be the private insurance as opposed to group insurance?
It's individual coverage where individual underwriting is done.
Individual coverage.
We feel that it is appropriate to maintain equity in our underwriting process to get this test because it gives us an objective benchmark with which to make a decision.
You're talking about individual policies and small groups?
And small groups.
Okay. Now, Ms. Lenhart, you represent Blue Cross Blue Shield, which is group insurance. Individuals are part of a group. And as I understood your testimony, you're not suggesting you want to exclude people who have a positive on this blood test that indicates they may have been exposed to the virus. Is that true?
I think the vulnerable population for both of us is that individual coverage, and we do offer individual coverage. And that's where, as I mentioned, you're at high risk. We don't know of any Blue Cross and Blue Shield plan that wants at this point to use the blood test to determine whether somebody's been exposed to that virus.
But you do want for individual coverage to exclude those individuals from coverage, but for groups, you're not interested in excluding them.
For groups, I don't think it's not an issue. You're
It's not
correct.
an issue.
Why
isn't it an issue? Don't you have to pay for the health care costs of people who are in a group?
It's typical that for groups above, I think, 25, an employer is not going to exclude individuals. For groups smaller than 25, I think it is very much an issue, and because, again, it's a small population and there's higher risk. For groups over 25, I don't think it's an issue for either the commercial industry or the Blue Cross and Blue Shield. It's a small group and individual. We only know of, by and large, for our small groups, we don't exclude people. For individual coverage, we only know of 2 Blue Cross and Blue Shield plans that at this point are asking the questions, and those plans ask questions about other medical conditions, so they are not discriminating. They're asking the same question as they would ask if somebody has cancer already.
Now, most people in this country, could you pull your microphone closer when you respond, please? Most people in this country have health insurance coverage based on their jobs. Isn't that correct, Mr. Goldbeck?
Yes, sir, it is, and with the exception of roughly 43 or thereabouts % of small business which does not provide insurance, and a number of self-employed persons.
Now, when most people have their insurance because of their employment, that means they have individual policies, or does that mean they have group policies?
No, that means they are in a group. They're part of a group policy. It's that person out who's not employed or self-employed that has to go out into the open marketplace and shop for himself that is at highest risk, I think.
So now if someone wants to buy an individual health insurance policy, and you deny that individual the ability to buy that policy because that individual has a positive HTLV-3 test, 90% of those people that have that positive test are never going to get AIDS. What will happen to those people? Dr. Chambers?
I would take issue, I think, with that 90%. I think that's debatable. The figures thrown out are 5 to 19% will get AIDS in 5 years.
Well, let's take the 20% figure. That means 80% will never be able to get coverage, even though they're not likely to get AIDS.
Well,
will they be able to transmit AIDS, Mr. Chairman?
That seems to be the suggestion, but the question is whether they'll have coverage for themselves, for their own health care needs, whether they get AIDS or not.
I suppose I shouldn't try to debate the merits or the statistics of this test. The fact is, we believe that the risk is substantially high that a person who has a confirmed positive antibody test will go on to develop some sort of a significant illness within a relatively short period of time, and that risk being so high that we don't feel we can offer private individual health insurance, and consequently they're going to have to find coverage or help in some other fashion.
If people can't get insurance coverage for their illnesses and they do get AIDS, somebody's going to have to pay the bill. Now, we as elected officials at the federal level trying to come to terms with that. Do you have any recommendations for us as to who should pay that bill if they can't get insurance?
I don't see this as strikingly different from persons who have cancer or who have other very serious health problems. We have long since maintained that people who run a very high risk cannot be insured for individual coverage, and we feel a person that tests positive for the antibody test runs that kind of a risk.
Mr. Goldbeck, do you have any comments?
Yeah, I'm concerned about the implications of this trend, if you will, an analysis. An awful lot of this country is in small groups of one kind or another. That has been perceived as good public policy to support. If the employers and individuals are not paying for their own insurance, the rest of us will be paying for it through increased tax dollars and increased state allocations and surcharges to make up the losses for a new category of so-called indigent that have been forcibly made indigent rather than being indigent of their own historical economic status. It seems to me we could apply very much the same rule to anybody that smokes in fairly short order in terms of their risks. And I think that if we don't figure out a way to see to it that private sector employers can work in a responsible fashion to make this kind of coverage available to everybody who comes through their plans, regardless of the size, then it seems to me we are asking the federal government to establish a national health plan for all diseases of this type. And I think there's some very severe implications to such a statement.
Isn't the insurance principle to take the risks of the people who will get sick and spread it out among so many people that it's paid for and there's even a profit left over for the insurer?
I pay insurance. They design it and sell it. I suspect that's the principle.
And don't we have high-risk pools for drivers who've had a lot of accidents or people who live in hillsides where there are fires?
Yes, sir.
Has the insurance industry thought about high-risk pools for individuals who are likely to have AIDS?
A lady behind me, Karen Clifford from the HIAA, whispered in my ear a moment ago and reminded me that I should have said something about the high-risk pool idea. May I defer to her?
Certainly.
Have her
Good morning, Mr. Chairman. My name is Karen Clifford, and I'm an attorney with the Health Insurance Association of America.
Could you speak right into the mics?
Surely. The health insurance industry has long been very much concerned with the problem of uninsurables, those that are unable to, because of their health status, obtain quality health insurance. We have recommended a federal approach to this problem. Representative Kennelly, in July of this year, I believe, introduced H.R. 1770, which would create incentives for states to establish state pools for uninsurables. This is a bill that the HIAA has been in full support of, has endorsed, and has lobbied for vigorously. What you should understand, and what Dr. Chambers has so well represented on our behalf, is the fact that we are faced as an industry with statistically significant figures regarding the antibody test. 5 to 19% of those that test positive will go on to develop the AIDS complex within 2 to 5 years. An additional 25 to 30% will develop ARC, AIDS-related complex, in and of itself a condition that carries with it substantial medical expense. Dr. Chambers would be better able to explain exactly what conditions are present in ARC. However, from an insurance standpoint, it is our responsibility to protect our policyholders as best we can, and that means that we must, as an industry, be able to utilize all valid predictors of increased risk.
Thank you very much. I'm going to move on to the other members, and I think in the course of the questions by the members, we should get all these opportunities to discuss this issue. Since I took, I think, 10 minutes, gentleman from California, Mr. Dannemeyer, will be recognized for 10 minutes if he wishes to use that time.
Thank you, Mr. Chairman. I'd like to ask Ms. Lenhard to tell me about group applicants today. Are applicants to a group questioned about cancer in their family background?
They can be for primarily the purpose of a waiting period, say a 6-month waiting period, and they're generally covered in full. In some groups, the smaller groups, although Blue Cross Blue Shield plans tend not to do this, say a group of 6 people, there are instances where a person will be carved out and excluded for coverage because they already have a condition.
Because they have cancer in their family background?
That's right.
Now, what's the difference between a person testing positive for HTLV? Is there any qualitative difference between such a person testing positive, being excluded from a group, and apparently being treated the same way that a person with cancer in their family background is being excluded?
Well, as I say, we tend not to do that. We tend not to exclude individuals regardless of the group size. But I think the response would be that that individual who has the presence of the virus may not be incurring medical expenses. What we would be concerned about is whether that individual is presently or imminently about to incur medical expenses. I think that's perhaps why we have not been interested yet in using the blood test, because there's no immediate evidence that that person will be hospitalized or incurring high medical expenses.
Well,
also,
that's puzzling. Is that an applicant to a group with a family history of cancer, not cancer in the applicant, but just a family history of cancer, is excluded?
not by Blue Cross and Blue Shield. You have to understand the difference.
Oh, you don't exclude them?
No. We
just have a waiting period.
Perhaps a different corporate mission here than somebody who...
Well, you talked about a waiting period, is it?
Well, Blue Cross and Blue Shield plans are not in health insurance to make a profit. I think the commercial companies have an appropriately different responsibility. They have a responsibility to make a profit. Their stockholders would not want them to seek out or cover bad risks.
Wait, did you tell us that there is a waiting period for an applicant whose family history has cancer?
That would be if the employer wants it. That is not up to the insurer.
Well, in some cases, in groups, if the employer asks for it, then it would be at least a waiting period. Is that right?
4 to 6 month waiting period. It's not common.
It's puzzling. See, the applicant would not have cancer, just a family history of cancer.
No, we would not do it for family history of cancer. I'm sorry.
But here we have an applicant with a virus in the blood. 10 to 25% of them are going to get AIDS. And if I understand what you're saying, so far as the Blue Cross Blue Shield is concerned, there should be no restriction on such an applicant with a virus in their blood becoming a part of the group.
But we would not require a waiting period where you had just a family history of cancer. You'd have to have cancer. And it would not be us, it would be what the employer wanted.
Oh, I see. Now, if the applicant has cancer, then they require
The employer may want a 6 month waiting period.
What's the status if the applicant merely has a history of cancer in the family? Is there any waiting period for that person?
No.
But routinely for Blue Cross group membership, is an applicant asked if there is a family history of cancer?
I've never seen that on an applicant, and I've seen a number of them.
How about the gentleman, Mr. Goldbeck? You're connected with the health insurance industry casually?
Casually? Our organization is an organization of employers, sir, so we're, from a representational standpoint, I don't purport to represent the insurance carriers. We pay a lot of money to them for services in the course of a year, but that's a different role.
I'd like to ask Ms. Lenhart, does Blue Cross have any idea of how many AIDS patients it has paid medical bills?
No.
Has Blue Cross developed utilization protocols for AIDS? For instance, do you require pre-admission approval before reimbursing for an AIDS patient's hospitalization?
We require pre-admission certification for all hospital admissions. Just about all Blue Cross plans do that, but they would not single out a separate procedure for AIDS. It would be treated like any other disease.
As an employer paying the blues, you would have less pressure about an AIDS case on pre-certification than you would on many other things. It's highly unlikely that somebody's going to try and abuse the system by getting excess treatment for AIDS. I mean, the pre-certification process is really designed to protect against something else that way.
At the present, I'd like to ask Mr. Chambers from Indiana, or Dr. Chambers, excuse me, is the health insurance company that you represent, is it presently excluding persons from coverage in groups that have tested positive for an AIDS virus?
In our group line, we do not, except for the small groups, have any individual underwriting. There is no underwriting that takes place of the individual. Only the group as a whole is underwritten. And so we would have no reason to be asking for any evidence of insurability, including an antibody test, on someone covered with group insurance. The vast majority of our group policy holders are in relatively large groups where this applies, where there has been no individual underwriting. On the small groups where we are allowed to do, and do in fact do, a limited amount of underwriting, ask a handful of questions, we are not at the present time asking any questions that hit directly at the subject of AIDS, nor are we thinking of getting antibody testing for those people. We would like to, as I mentioned earlier, have a right to use the antibody test, and we definitely feel that it has a very strong place in the individual contract area, both life and health. But for group, I'm not sure that it has a significant role to play.
What's the break between a small group and a non-small group?
In our company, I think the cut point is at 25. It's 25 or 50. It's in that range.
Would your group condition of insurability want to know if an applicant in fact had AIDS?
Who would want to know, sir? I'm sorry, I don't...
Supposing you had a new employee of a group plan, would you want to know if that new employee in fact had AIDS before you covered him?
That new employee would be automatically covered in the group plan. When they come to work and become an employee, then they are automatically covered.
And if they come in with AIDS, then they're covered?
That's correct.
Thank you. I have no other questions, Mr. Chairman.
Thank you, Mr. Dannemeyer. Mr. Scheuer?
What's the purpose of giving the test if both existing employees and new employees are covered no matter what the results of the test show?
Well, again, it's a matter of differentiating between group coverage and individual coverage. For group coverage, as a generality, there is no individual underwriting, and so the test is irrelevant. We don't...
So you wouldn't give the test?
No, there's no underwriting involved at all. We don't ask for any medical evidence with a group, in a group situation, whereas with the individual contract, where underwriting is done, where medical history is inquired about, where a person may have to have an insurance examination. It's in that setting that we feel, in order to identify those who have been infected with the virus, clearly the most objective way to do that is to use a series of antibody tests.
Well, now, do you use the antibodies test now to screen applicants for individual insurance policies?
We do. Mike, you're talking about the industry or my company?
Your company.
My company does not use this test at the present time. We have given very serious thought to doing so. And I would anticipate that we probably will do so sometime in the next 6 months or a year. But we do not at the present time do so.
For individual policies?
For individual policies.
The HTLV3 antibody test has been licensed for use, as you know, only in transfusion products. And it's specifically labeled against use for screening. And apparently the principle is that the product hasn't shown to be effective for screening. I'm told that using the test for purposes other than blood banking is a violation of the Food and Drug Law. You say you're contemplating using the HTLV3 antibody test for screening applicants. On what data? On the basis of what data? On the basis of what advice on the law as it exists now are you contemplating doing this?
Well, first of all, it's a test that I think is believed to be quite reliable by a very large number of people. It is felt to be reliable by the military. They're using it now. It's felt to be reliable by many people out in the medical community who are doing this test on patients who come in, who have some sort of symptomatology, the nature of which is not known for sure, and the attending physician will order this test. If the test is positive, the attending physician is aided in making a diagnosis of this condition being secondary to infection from the HTLV3 virus. It's a test that, from everything we read, is connected with significant risk of developing AIDS within 5 years, 5 to 19%, 25% chance of getting AIDS-related complex within 5 years. These are fairly hard figures that are repeated over and over.
What would an AIDS-related complex be?
AIDS-related complex, by definition, is a condition whereby the person has been infected with the virus, and the virus, in turn, causes some degree of impaired immunity, which then leads to certain things like lymph node enlargement, chronic unexplained diarrhea, weight loss, fevers, night sweats, various signs and symptoms of infection. And it's a combination of impaired immunity and signs of infection short of a very serious opportunistic infection, which would make it AIDS. So it's a lesser AIDS condition. And some of these people become very ill, become disabled. In fact, you can die from AIDS-related complex.
Gentlemen, yield to me for a clarification of the last question you asked. The question was, since the FDA has licensed this test exclusively for the purposes of screening out any blood where there's a virus in it, presumably that would be a violation of the law for you to use that test for any other purpose. How do you square that with the practice of using the test?
Let me say that that's one of the reasons that we haven't started using it yet. We seriously want to explore that and every other issue surrounding this test, and there are many issues that are not clear-cut in terms of all of the things that we need to know. We need to know about how we should most effectively, if we do begin using the test, how we should most effectively give pre-notice to a person that will be tested, how we would go about giving effective post-notice if a test is positive, how do we inform that person, and how do we help that person to seek the medical attention that they need to seek. There are lots of questions. How do we maintain confidentiality, which we know is very, very important. We want to think through all of these things, including the legalities of it. So that is the reason why we have not yet adopted the use of this test. We do know, however, that from a scientific point of view, it has the capabilities of giving us a much more objective, fair measure of risk than anything else we've got at this point in time.
Well, it's been enormously interesting listening to this panel, and it does raise some of the most agonizingly difficult public policy problems. There are no simplistic answers here. I can understand the wish of the industry to control their costs and not take on undue health or illness risks unnecessarily. Having said that, the remaining public policy questions are extraordinarily difficult and challenging, and I suspect we'll be taking up the time and attention of this committee for some time to come. Let me revert to a question that we've been asking before, which is cost. As insurers, you have to be concerned with cost. Have you found any cost differences in various parts of the country, or as between hospitals, as between care providers, that have any lessons for us, that can give us any lessons as to how and under what in what kind of setting we should provide care for AIDS people, AIDS patients, at the lowest level of sophistication and cost, and with the greatest compassion and caring that is possible. The lowest level of sophistication and cost that's consistent with their medical needs. What have you learned that you can impart to us from analyzing differences in costs from city to city and from care provider to care provider?
I would say that at this point in time, we have very little data, but I did refer in my testimony to the fact that the Health Insurance Association of America is currently putting together a survey of all its member companies to ask these very questions that you ask. Differences in costs, different parts of the country. And we are very hopeful that that survey will yield some meaningful information. There is this one point that I made a while ago, that it is very hard for insurance companies to know for sure that claims that they are looking at are in fact AIDS claims. So the information we generate from that survey will be less than it could be otherwise if these cases were clearly labeled. But we are hopeful that this survey will yield some information, and we will share this with the committee.
As somebody mentioned, I don't know whether it was this panel or the one before, that doctors are reluctant to put as the cause of death AIDS.
Mr. Shore, I'm going to have to interrupt you. We've had the second bells for a vote on the House floor. We'll recess now and come back, and we do want to ask some more questions of this panel, so please remain, but we'll recess now for 10 minutes.
Fascinating subject.
We'll return to our coverage on the cost of AIDS treatment in a moment. Right now, we pause for a look at our program schedule for the next several hours here on C-SPAN. This hearing continues for another hour and a half. Then at 8:30, El Salvador's President Jose Napoleon Duarte discusses terrorism in a speech before the National Press Club. At 9 a.m. Eastern Time, that's 6 a.m. Pacific Time, Paul Warnke, Chairman of the Committee for National Security, is our guest on a previously recorded viewer call-in show. Then at 10 a.m., the Senate Rules Committee votes on a proposal to allow television coverage in the Senate chambers. At noon, the House Foreign Affairs Committee holds a hearing on Soviet foreign policy in the United Nations. Jose Napoleon Duarte, President of El Salvador, addresses the National Press Club at 2:30 p.m. Eastern Time. And we will re-air highlights at 3 p.m. Eastern Time from our visit to Montgomery, Alabama from this past week. And finally, at 6 p.m., Walter Pincus, national security correspondent for the Washington Post, is our guest on a previously recorded viewer call-in show. That's a look at our program schedule for the next several hours here on C-SPAN. Right now, we return to our coverage on the cost of AIDS treatment before the House Subcommittee on Health and Environment, chaired by Democratic Congressman Henry Waxman of California.
Meeting will come back to order. Mr. Scheuer was in the middle of questions, and I think he has 2 minutes left, so we'll recognize him for finish up on his question period.
Well, I was asking the panel if any of them, from their own actuarial experience and oversight experience, could give us any advice on what we can learn from the differences in management practices between cities and between health providers in the costs of managing AIDS patient care.
Yeah, we have just had a series of discussions, including earlier this morning, with people who have been assessing the costs in San Francisco and the methodologies used there. And it appears, based on studies conducted through the city and by anecdotal experience from employers and the University of California, that one of the major determinants is the degree to which intensive care is used. Many AIDS victims, if you will, end up in extensive periods of intensive care, which apparently, based on the groups out there, are not medically necessary. And in San Francisco General Hospital, since that was mentioned earlier, we'll stick with that institution, a typical case where intensive care is the principal modality runs that $17,000 plus that you heard of by the first panel as being a typical cost.
Well, we heard $875 a day, I think it was. That's a lot more than $17,000.
What can be? I'm talking about an average, though, as to what it came out.
What kind of care would that mean, and what aspects of the intensive care would be superfluous?
I cannot answer that from a medical standpoint. I unfortunately am limited to responding to you on the basis of the frequency, the period of time, and the alternative location modalities that a person could receive care within, and very much in the same spirit of your earlier remark when you noted that the care could not only be more cost efficacious but also more humane. Because when home care and hospice was used, the average cost was $8,600 instead of the $17,000. And that's a pretty dramatic difference considering the number of people we're potentially talking about, or even if it was close to that difference. And so there's a good indicator there. The numbers will become more precise over time, but it's a darn good indicator of the direction we ought to go. I think it does suggest that one of the comments made by the first panel ought to be listened to very carefully, and that is we should assess the ability for hospices to provide adequate care within the current reimbursement structure for hospices. It may very well be that a slight boost to hospice care reimbursement could result in a very dramatic reduction in unnecessary care elsewhere.
Gentleman's time has expired. Mr. Lucan?
Dr. Chambers, I take it from your testimony where you say it is the industry feels that it's incumbent upon us as insurers of the population at large to do all we can to detect the minority of applicants who have been infected with the AIDS virus. I take it from that and your other testimony that you want to test all of your insureds. I don't see how you could accomplish what you're saying here unless you want to test all of your insureds, which means testing most of the population.
No, we have no thought that would make any sense at all.
Don't you insure your association? Don't your insurance companies insure, doesn't that comprise something like 85% of the insurance industry? Or what percent of the insurance industry does it? Health industry?
The Health Insurance Association of America,
Yeah.
that's right, represents 85% of the health insured.
Commercial.
That's correct. Commercial, and I'm sorry, commercial health.
But when you make a
insurers.
statement like this, it seems to have a pretty sweeping kind of effect. You're going to detect, as insurers of the population at large, and I suppose you are insurers of the population at large. What are you going to do with that information after you have everybody tested?
Well, we don't intend to test everyone.
Well, how are you going to protect all the population at large if you're not going to test everybody?
The AIDS epidemic, as it stands today, is an epidemic that is confined to certain large metropolitan areas. I think that...
If I may interrupt, though,
Yes.
I think you have properly and cogently stated that we don't know, that your other parts of your testimony, that we don't really know a lot about this. And it may be more than 5 or 19%. And it may be really outside of those metropolitan areas. And it may, if it isn't now, it's going to be.
You're absolutely right. There's a great deal that is not known. We just hear these estimates of perhaps 1 million people that have the virus living in the United States, and we know that that's a population of people that present a significant risk to the individual health and life business. Earlier, it was stated that perhaps 85 or 90% of persons who are positive for the antibody will not go on to develop AIDS. I'd like to make one point, if I could, to give you a...
I'd like you to answer my question along the way somewhere, but if you want to make a point, okay.
Well,
You haven't addressed my question yet.
companies at this point in time do not know what would be right and what they want to do in the way of antibody testing. They are exploring the possibility of doing antibody testing, but we simply want to have a right to do antibody testing if we feel that by doing that, we would be able to maintain equity in the underwriting process.
Now,
We don't know the mechanics.
You're telling us you want the right to do it, but you're really not going to do it?
No. What we're saying is that we need to, as we learn more, as our thoughts evolve on this subject, we would like to have the opportunity to ask for it if we think it's the best thing for us to do in order to protect our policyholders.
Well, I admire your candor. If you put that in the context of your very clear statement that you want, the industry feels it's incumbent upon it to protect the population at large from that minority who may have AIDS, and you're going to have this information, you're going to use it. Obviously, you're going to use it. And you're going to use that ability to make the test, to take the test, you're going to use it widely. You've stated it here, and I don't think anybody doubts that. And without making any judgments, the representative from Blue Cross takes a totally different tack. He says, we know of no case where a Blue Cross and Blue Shield plan is using a blood test to identify the individuals who have already contacted the virus. And we know of no case where questions are asked about lifestyle in an attempt to identify a vulnerable individual. Well, let's get to that question. Do you ask questions about lifestyle?
No, we do not ask about lifestyle if you're referring to homosexual lifestyle. That is not
Well, I'm
something that-
talking about the obvious lifestyle we're talking about in this case, yes. I assume that's what...
We've never asked about sexual preference and do not intend to ever do so. It is not
Well,
something...
how are you going to protect the population at large who are your insureds? How are you going to protect them from being lumped together with the AIDS virus carriers if you don't ask them about lifestyle? Certainly that's a pertinent question, isn't it? It would be in any kind of an underwriting scheme, wouldn't it?
Karen Clifford would like to address that if she may.
Mr. Lucan, when we speak of protecting the policyholders at large, we're talking about the financial solvency of an industry.
Of course, I understand.
The insurance industry is based on finance. Obviously, we have to take into account what risk we're taking on so that we know and can accurately predict what premiums we should be charging. And your statement earlier about the fact that not much is known about this illness at this point in time is quite correct. In spite of that, as an industry, we are faced with recent legislation in several states that have served to prevent us from using what is currently state-of-the-art tool in picking up increased risk in this new illness.
But when you talk about premiums, that's would be a consideration. But you can set the premium high enough to take care of the whole population, can't you?
And to do
if
so,
you represent 85% of the insurance companies, if you don't pay for it, to get back to the chairman's question a bit ago, if it's not paid through private sources, what are you planning to do? Dump it on the federal government, or let people go uncared for, or dump it on the hospitals?
The reason we're here today, Mr. Lucan, is to try and avert the possible problem of individual prices, the price for individual insurance becoming so astronomical that individuals can't afford to buy it in the first place.
Well, we're not talking about just individuals.
We're talking about instances where individuals are subject to individual underwriting standards. By and large, that includes only individual insurance.
Individuals in small groups, and I think in the whole context, it's clear that what you're getting to, as I say, we admire Dr. Chambers' candor, and he may well be right, but my own purpose right now is to just identify what people are saying and where we're going. And we get back to the question, the insurance companies clearly, if we take Dr. Chambers and your testimony, are out to exclude the AIDS sufferers, those who are afflicted with AIDS, and who's going to underwrite it, who's going to pay for it if they're not taken care of as others are, as the cancer victims are, as others who are faced with astronomical health charges, if they're not going to be taken care of as other sufferers of serious disease and expensive disease, then who is going to pay for it?
Mr. Lucan, the industry has been instrumental in establishing mechanisms to address those needs in a number of states. Currently, there are 8 to 9 states in the country that have pools for uninsurables in place. The way these pools operate is by letting high-risk individuals into the pool and charging those individuals a somewhat higher than normal rate, and these are all individuals that, because of their health status, cannot otherwise obtain insurance. The health insurance community, the commercial insurers in particular, are then assessed large amounts to help finance the losses that these pools incur.
Well, that's what's been happening up to now, hasn't it? That's how you've taken care of all of those who are afflicted with disease and illness.
Yes, AIDS as any other illness.
But clearly you're saying that this is different.
No, we're not.
You're going
That's not
out
our contention.
on what could even be a witch hunt. You're going to test everybody, apparently, or you're going to test a lot of people. Certainly, in order to accomplish what Dr. Chambers said, you're going to have to test a lot of people. You know, if you're going to protect insureds, the population at large, and you're going to protect your insureds.
There is no witch hunt going on here, I can assure you.
No, I don't say that there is, but if you did what seems to be implied here, that you're going to, it seems to be implied that you're treating AIDS differently from an underwriting standpoint. That's what I'm getting out of it.
No.
That's what I'm trying to clear up.
Let me try to clear up that
just
misunderstanding.
one moment. Mr. Gentleman over here from Golbeck, he pointed out, and I think in contradistinction to Dr. Chambers' testimony, that this shouldn't be considered any different from plagues or epidemics or serious diseases that we've had in the past, at least as far as insurance is concerned. And I'm just a little concerned. I hope you don't mean it, that I misinterpreted. I'm just a little concerned that you're saying it would be different.
We do not want to treat AIDS any differently than any other serious impairment that's out there. We want to underwrite individuals and look for their risk of having the AIDS virus, just like we look for individuals for hypertension or for any other serious health disorder. And we do a lot of testing in the insurance business. Antibody testing, if we were to go that way, would not be unusual. We do all sorts of blood testing on insurance applicants. So we want to treat AIDS like any other
Incidentally,
illness.
I'm not necessarily against the testing, and I'm not making any judgments as to where we should for the purpose of this discussion, of where we should be requiring the blood tests or not. But for the insurance companies to be requiring the blood test for underwriting purposes, I think that does create a problem.
Gentleman's time has expired. Mr. Nielsen?
Yes, thank you. First, I'd like to commend Mr. Goldbeck for what I consider a very good statement, very positive statement, one of the most positive I've heard. You mentioned 4 things. You said that AIDS should be treated the same as any other illness. Should be the same confidentiality, should not be subject to exclusion, and should have the same group rates. I'd like to ask Mrs. Leonard and Dr. Chambers if they agree with all those 4 points.
Absolutely.
Now, you mentioned that's for group rates. What about for individual costs?
We don't, Blue Cross and Blue Shield plans don't tend to charge different rates in the individual market.
Maybe I should rephrase the question. Mr. Goldbeck, yours applied to both group rates and individual rates. You have those comments, did it not?
From the standpoint of our organization, we don't have any individual policyholders. We're an organization of large employers.
I understand, but do
so
the
I didn't
principles
make it from that standpoint.
But do the principles you espoused, would they apply to group individual rates as well?
For individuals, I would support the idea that individuals ought to have access to the insurance, but it is certainly reasonable that their rates, if there is a legitimate, proven methodology of risk assessment, I think that's a question at this point, but
so
if there is one.
You'd back off from these 4 other positive things when it comes to individual rates then?
I'd say there's a different method of assessing the rate structure for individuals than there is for groups. There always has been, and I believe there will continue to be.
That takes the heart out of my question. If you're going to stick with those all the way through, if they in fact AIDS is simply a similar disease to some other things that ought to be treated the same way, then that ought to apply both to individual and small groups as well as to large groups, should it not?
The current method of rating individuals and small groups already takes into consideration people's risks for particular illnesses. AIDS would be one more on that list. It would not be an alteration in that policy or rate-making structure.
Okay. Well, then, that took some of the steam out of the argument I was going to raise. But Dr. Chambers, would you agree? Mrs. Leonard apparently agrees with these 4 points as far as group policies are concerned. Do you agree with those?
Could we go over those one more time?
All right.
I don't want to.
AIDS should be treated the same as any other illness.
We agree with that.
Okay. It should have the same confidentiality.
Absolutely.
It should not be subject to exclusion.
I guess I don't understand that.
Cannot be excluded from the group, in other words.
Okay.
You agree with that? Mm-hmm. And it should have the same group rates as anyone else. Yeah. So you agree with all those things as far as the group's concerned?
Sure we do, yes. Mm-hmm.
Let me ask you about the California-Wisconsin decisions that were made. Did you do any lobbying either way on those bills in California and Wisconsin?
It's my understanding that both bills were passed before our industry knew that they were going to be enacted. We did not play any role in putting those bills together.
You indicated you didn't think they were wise rules. Would you lobby to repeal them in the 2 states involved?
We are, in fact, attempting to do that at the present time.
Ms. Leonard, what about you? Do you have any comments about the California-Wisconsin laws to which Dr. Chambers referred?
Now, as I said, I know of no Blue Cross and Blue Shield plan that's interested in using that blood test, so it's not been an issue.
So you would not, would you lobby to repeal those laws in those 2 states if you had the opportunity to?
I don't know. I would have to check with those individual Blue Cross and Blue Shield plans and get back to you, but I know we have not heard anything about their being interested in lobbying that issue.
Maybe I can engage the Congressman in California, either Congressman, about the law in California. Mr. Chairman, if you'd like to, do you know of any attempt in California to repeal that law which involves the blood test as far as AIDS is concerned in insurance practices for the state of California, also in Wisconsin? Do you know of any attempt to lobby that to either repeal it or to extend it?
Gentlemen, I don't know about that, but the witnesses on the next panel may, so if you'll withhold that question for them, I think...
What about the other congressman from California? You know anything about that? I'm interested. California usually the leader in these things, either positively or negatively, and in this case, they seem to be in the negative direction. I just want to know if these 2 congressmen from California have any advice so that we can prevent this from spreading to the other 48 states.
Having served in the state legislature in Sacramento for 6 years, I'm not surprised at anything they do.
I'd like to return to Dr. Chambers. Just one question. You seem to imply in questioning from Congressman Lucan of Ohio that you do want to have the blood test available, but you didn't come out with a definitive statement. At least I didn't. Do you want to use the blood test or don't you? I never did get the answer because you hedged on it so well that I'm not sure it satisfied Congressman Lucan. It didn't satisfy me.
Mr. Nelson, that is a question which the industry is right now trying to assess. We're trying to look at what is the appropriate direction to go in. I speak for a number of companies, as does Dr. Chambers today, and what we're trying to do is collect as many facts as we can and move forward as intelligently as possible. We have no desire to discriminate or to underwrite according to lifestyle. And so I guess a brief answer to that question is we're just trying to get the facts and do what is appropriate and safe and sound economically.
Would the gentleman yield?
I'll be happy to yield, gentleman from California, on this point.
I sense what is coming from you representatives of the industry is this, that if this AIDS epidemic reaches proportions that some of us hope it never will, but some people say it will, you may re-examine your position about asking for tests on the presence of the AIDS virus in an applicant, even of a group, just for the sake of the financial solvency of the plans that you represent. Is that a fair summation?
I think the answer as to whether this AIDS antibody test is valuable will become clearly more visible as the epidemic spreads. I agree with that. I don't think we'll ever, in group insurance, large groups, get into individual underwriting of any kind, including the underwriting for AIDS. That's just not going to happen. But for individual coverage in small groups, I agree with you. If the epidemic continues to spread, we will absolutely have to do something. We will not be able to sit back and simply think about the problem.
One other point, thank you. Congressman Lugan asked you about testing individuals. It was never your intent, even if you planned to test individuals, to go back and test your present policyholders.
Absolutely.
It would only be the brand new ones.
That's correct. The present policyholders are guaranteed by their contract for the amount of insurance they applied for, the premiums that they pay.
Okay. Let me ask a question. Congressman Dannemeyer is a very modest individual, but he does have about 5 legislative initiatives regarding the AIDS proposal, and I may have him jog my memory as to what they are, but one of them allows medical personnel, hospital personnel, to wear protective clothing if they choose to in dealing with known AIDS victims. Would you oppose or support that particular one? Any of you?
It is certainly my understanding that there must maybe an exception somewhere, but that is the norm in hospital and medical policy today, certainly as the purchasers of medical care, the protection of both the provider of care and the patient of care by clothing or other apparatus is an entirely a prudent and appropriate thing to do should they so desire.
So you would allow the medical or nursing personnel to wear a special kind of clothing. You wouldn't object to that?
Certainly not.
No. Would you object to requiring isolation of AIDS patients from the other hospital patients in the hospital?
From my knowledge of this, I would say that isolation ought to be predicated only upon a medical determination that that is the way to handle the treatment of AIDS and the protection of other people from its potential spread, and I do not see anything that suggests in the literature thus far that that's a necessary step.
I'm going far afield, but let me ask you one more. Do you believe we should isolate the children going to school who are diagnosed as having AIDS? Isolate the children who have AIDS from other children. I know this is beyond the scope of the panel.
These are insurance people, not public health experts.
I admit I was going far afield. I just want to know how far their non-discrimination is going to take us, and that's why I was asking the question, but I'll withdraw the question at the chairman's request. But it's an interesting question. It's causing a lot of concern in some school districts in the country.
Mr. Chairman, I think these witnesses are just chafing at the bit for the opportunity of answering that question. I think they should be asked as citizens of this country to answer that question if they want to.
We have Mr. Nielsen. Mr. Nielsen's been recognized to ask questions. If he wants to pursue it, he can pursue it.
I withdrew the question, but think about it in terms of how you handle the problem. It's a very difficult problem.
It is a difficult problem, and let me say from my perspective that we have to be prepared to take any steps that would legitimately stop the spread of this disease. That's got to be our highest priority, and I'm sure every citizen would agree, every person would be equally concerned about it, and we're interested in hearing ways to stop the spread of the disease. And that will be the subject of other hearings, I'm sure, that we'll have, as it has been in the past. This one is on the question of how are we going to pay for the health care for those who are undoubtedly going to have the disease. We want to, Mr. Nielsen, if you've
I'll be happy to. I just simply mentioned there are 5 such bills coming. I just outlined 3 of them that I know about, and there are 2 others that I'm not too familiar with. But we're likely to have a number of bills involving this, and while they may not impact on the insurance industry directly, I think they impact on the spread of AIDS and the fear of AIDS that's rampant in the country, and it may influence what you do in insurance. So I thought you should be aware of them. Thank you, Mr. Chairman.
Thank you very much for being with us. Your testimony has been very helpful. We're now going to break for an hour and then come back and finish off the hearing. So we'll convene at 2 o'clock. And we'd like to ask you to respond to Dr. Chambers and Ms. Lenhart. We'd like, and Mr. Goldbeck, to respond to questions for the record. There's some questions we would like to have the answers to. We'll reconvene in this room at 2 o'clock. Meeting of the subcommittee will please come to order. To now call forward Councilman Joel Wax, Councilman for the City of Los Angeles, and Mr. Brent Nance, CLU AIDS Project LA. If you'd please come forward and take a seat at the table. We want to welcome both of you to our hearing today. As I indicated to the other witnesses, and I regret the delays in getting to your testimony, we've had on the floor of the House probably one of the most important items that we'll have in this Congress, and it's been known as Graham-Rudman proposal to set in motion very deep cuts in health care and other programs that the federal government sponsors. So in some sense it's appropriate that we're having this discussion at the same time. I apologize to you for the delay, and we're looking forward to hearing your testimony. I'd like to request of you to summarize your testimony in no more than 5 minutes, and we'll make the full text of your statement part of the record. Let's hear from Councilman Wax first.
Thank you, Mr. Chairman. 3 months ago, Los Angeles made history by becoming the first city in the United States to prohibit discrimination against people with AIDS. And I'm pleased to report that our historic law is working. Because of this landmark legislation, it is now illegal to discriminate against any person with AIDS in employment, housing, business establishments, healthcare facilities, or educational institutions. This law is not just a legal document, but it's Los Angeles' promise that those who face their most profound moment of loss won't be shunned aside because of ignorance, bigotry, or fear. We ask that these protections be extended nationally, for not only does discrimination strip an innocent person of his dignity and rights, but it has a direct negative impact on the issues you're examining this morning, namely the escalating cost of AIDS and the manner in which those costs will be borne. The shifting of costs from private insurance programs to federal and local governments is directly related to discriminatory practices. When one loses his job or is otherwise denied insurance, the ultimate cost will be borne by the public. Employers must be prohibited from acting out of fear and from firing capable employees because of what other employees or customers might say. Insurers should not be permitted to refuse coverage through the use of HTLV-3 antibody testing or through lifestyle screening, which could potentially deny coverage to all single men between 19 and 50. Lifestyle screening, which, by the way, Lincoln does advocate, raises the most serious and legal and ethical questions. It denies people their most cherished of all rights, their right of privacy. And the use of antibody testing for insurability will not only shift the medical costs of AIDS to the public, but will deny coverage to millions who may never be diagnosed with AIDS. It will also punish the very public which is intended to benefit from medical research. For the use of any newly discovered early warning test as a screening mechanism for insurability could have sweeping repercussions. It could set a dangerous precedent that every step forward by medical science will be accompanied by 2 steps backward by the insurance industry, and the very people meant to be helped by medical technology will be the victims of insurance discrimination. Furthermore, discrimination actually increases the cost of medical care as well as shifting it. If nursing homes refuse care for people with AIDS, the result is needlessly prolonged stays in expensive hospitals. We cannot permit discriminatory practices which unnecessarily increase costs or cause large shifts in responsibility from the private sector to the public. We must continue to look to private insurers to maintain their traditional role as primary providers. There must be protections against arbitrary discrimination which deny insurance to broad classes of people. Use of HTLV-3 antibody testing and lifestyle screening, already illegal in California, must be prohibited nationally. Employees with AIDS must be considered as any other medical problem, with attendant health insurance, absence and disability, and the protection of privacy. And if a person does lose his job, we must provide portability either by mandatory portability clauses or even the use of Medicaid to pay the premiums needed to continue coverage. Even with these protections, private insurance benefits will not always be available to those who need them. In such cases, we must look to changes in Medicaid to help fill the gap. Eligibility criteria should be re-examined, and reimbursement for experimental drug therapies, psychotherapy, and matrix care programs should be given urgent priority. Mr. Chairman, you don't have to have AIDS to care about someone who does. All it takes is a little human decency. I commend you personally for your leadership in this most extraordinary national crisis. I think it's incumbent upon all of us to throw aside our prejudices and join together in an all-out war on the AIDS virus and not on its victims. Thank you.
Thank you very much, Mr. Wax. Mr. Nance?
Mr. Chairperson, thank you. Never before has a disease caused such widespread panic and fear with the public, the insurance industry, and healthcare workers as has AIDS. High medical costs, the fear of the unknown, the CDC's insistence on labeling this epidemic as a disease of gays and other less desirable populations have all contributed to the sorry state of affairs. AIDS is the largest healthcare problem this country has faced since polio. In this epidemic, governments, insurance companies, and various conservatives are coming out to abdicate their responsibility in addressing AIDS. The hard facts are that the cost of AIDS in suffering, death, dollars, and productive years lost will continue to mount and will be borne by all of us. Insurance carriers, HMOs, and ERISA plans are considering ways to reduce, avoid, eliminate, or reject their normal responsibility for the treatment and financing of AIDS cost. These groups should be part of the solution, not part of the problem. Instead of looking for ways to avoid all AIDS claims, they should be supporting lower, more cost-effective methods of health care. HMOs have been slow to address AIDS from a health care basis. Many are not equipped nor properly trained to handle the medical needs of AIDS patients. Even so, they almost always refuse to refer their patients to adequate outside medical care. ERISA plans are virtually unregulated and can do almost anything they wish with benefits. Conversion policies and disability extensions are not mandated by the laws. They currently already have the ability to exclude AIDS from coverage. All public health care is provided through either Medicaid or Medicare. The California State AIDS Advisory Committee estimates that in California, approximately 61% of all AIDS patients will end up on Medi-Cal. Numerous and serious problems have occurred. The majority of these problems occur because of the inability to qualify, the high co-payment cost, the high monthly deductibles, and the low level of reimbursement for AIDS claims. The burden of care under our system falls upon county hospitals and public nonprofit hospitals. Overutilized, overcrowded, and underfinanced facilities are already reaching their breaking point. The burden falling upon these overtaxed systems will further increase if the industry succeeds in limiting its obligations. The industry, HMOs, and ERISA plans will have to take part in the financing of AIDS care. Laws may have to be passed to prevent them from excluding AIDS requiring special blood test or from redlining. Because regulators are either unwilling or unable to regulate the industry, the federal government will have to address the issues of mandating adequate and affordable conversion policies, adequate disability extensions, coverage during unemployment, layoffs, or termination. Full takeover of benefits when employers change from one carrier to another must be provided. The insurance industry must provide alternative, lower-cost health care approaches, public risk reduction and avoidance education, and help fund medical research. AIDS Project Los Angeles, Shanti San Francisco, and the Gay Men's Health Crisis in New York and other organizations have saved insurance and public health systems millions of dollars in care claims by providing care for AIDS patients in their homes. Home health care, hospice care, and home health aids coverage has either been non-existent or severely limited by the payers of health care, even though proven cost-effective. By financially supporting these nonprofit public support groups across the country, millions of additional health care dollars could be saved. Such an effort would be mutually beneficial to the public, the insurance industry, and persons with AIDS who want to be cared for and be allowed to die in their own home. HMOs either need to provide the proper level of health care or be willing to refer their patients outside their systems. Public health care systems will have to change. Everyone needs in this country to have access to health care. Instead of creating new programs, consideration should be given to using presently existing plans such as Medicaid and Medicare. Perhaps uninsurable people should be allowed to join these plans by paying on a sliding basis based upon income. Or perhaps a national health care assigned risk program should be created with the joint efforts of the insurance industry, HMOs, provider organizations, and public health care systems. Thank you for allowing me to participate in this hearing and to express my concerns and offer some possible solutions. We are all in this fight together, and together we will have to find ways to cover the cost of this epidemic. Thank you.
Thank you very much. I want to thank both of you for your testimony and express my appreciation to Councilman Wax, who's been such a leader in this whole area, coming from Los Angeles to present his views to us. I mentioned on the House floor today we're voting to cut government spending, and we're in the process of making deep cuts in Medicare and Medicaid. At the same time that we're finding that private insurers are concerned whether they can carry the financial burden of paying for the health care for AIDS patients. Mr. Nance, you mentioned a part of the AIDS care dilemma that I haven't heard about before, and that's HMOs. Have any people with AIDS that you've worked with at the AIDS Project LA had problems with HMO coverage?
Yes, we've had numerous problems with HMOs and care for AIDS patients. In many situations, the HMOs have refused to do proper diagnostic tests to verify the existence of AIDS. There is one HMO in California that is supported by Blue Cross that has even refused to treat a patient with anything more than vitamins because it's an incurable disease. Even when the HMOs do not have the experience necessary to treat an AIDS patient, they still refuse to send them to UCLA or one of the other institutions that are specialized in an AIDS
These are
care.
people who are already enrolled in the HMO?
Yes.
Do you know of instances of group insurance, either of small or large groups being canceled or significantly adjusted as a result of AIDS or fear of AIDS?
Not specifically cancel. We have seen group carriers refuse to quote on cases where they suspect that there's a high number of single males involved. There was a recent one in San Francisco where an HMO was willing to quote a bank and quoted that bank until they found out the bank was a gay-owned and operated organization and withdrew their quotation.
Mr. Wax, what type of insurance does the City of Los Angeles supply for its employees?
We have options. Some have Kaiser, some have Connecticut General. Employees have options of 3 different plans.
Has the AIDS epidemic changed the insurance coverage of the city?
No, because discrimination is illegal now in the City of Los Angeles, and it's illegal for employers to negotiate health insurance benefits that in any way discriminate against people with AIDS or people who may even be perceived to have AIDS and not be diagnosed as AIDS. We've explicitly outlawed that in our new legislation.
As the employer city of LA, has that law made it any more difficult for the city to have full insurance coverage for your city employees?
Now, at this point, the legislation is only 3 months old, but so it would be too early to tell.
Does your policy allow for conversion privileges if an employee loses his or her job with the City of Los Angeles?
I think it varies depending upon the employee, but the answer is yes for most employees.
And if an employee left to work at the City of LA under this conversion privilege, does the city help its disabled employees to pay for the expensive individual coverage that they would then have available to them?
I'd have to find that out, Mr. Chairman. I'm not
So Nancy,
positive.
you know the answer to that? You're shaking your head.
I don't know of any employer, including the City of Los Angeles, that helps finance the cost of a conversion policy. It's one of the big problems with AIDS and the system that we have for insurance is that once you lose your employment, you typically are going to lose your health insurance also. And if you're losing your employment at a time when you're totally disabled or facing a catastrophic illness, you're uninsurable, and to pay $6,000 or $7,000 a year for marginal benefits under a conversion policy is just exorbitant.
If I may, Mr. Chairman, the other side of it is that no one in the City of Los Angeles will lose their job because of AIDS.
Well, when an employee is sick and leaves, they're covered under the city health insurance, and
They can convert, but they can convert. I didn't know the answer
I mean,
to your other question as to
if
assistance.
someone's too sick to work, what happens? For any illness, and they leave the city employment, what happens to them?
They would go through their normal disability and all, and then they could convert their policies if they actually have to leave the employment.
But if they convert their policies, they convert it to an individual policy, which is very expensive, and Mr. Nance says the city doesn't help them pay for it.
And that's the information I have to ascertain.
Well, if you have anything more to add, we'll hold the record open for that point. Does the city ordinance that you've authored prevent other employers from refusing to give insurance coverage or provide for insurance coverage for an AIDS patient?
Yes. It would be a discriminatory employment practice. Employment practices under our ordinance include hiring, firing, or terms and conditions of the workplace that are different from other employees, whether they be benefits or segregation in the workforce, etc.
And do you know whether there's been any impact on whether employers are willing to employ people, whether you're hearing complaints about the violations of this law or not? What enforcement is happening there?
Most of the issues that we've had at this point are people who have been threatened with their job. And one of the things when I said at the outset that the law is working, we have yet to have to go to court and actually test this. Most of the cases have been resolved by bringing the parties together, by educating the people to allay the fears, and by having the law. We have actually found that many employers in the City of Los Angeles are glad that they have the law, because they could go to other employees or to customers who might say, fire the person, and say, no, we can't do that under the law. So we've actually found that landlords and many businesses are now beginning to find that the law is something that is a positive tool for them.
Thank you very much. Mr. Nielsen?
Thank you, Mr. Chairman. I have just a couple of questions. I was not here to hear your testimony, Mr. Wax, but I have a couple of questions in reading it. First of all, I congratulate Los Angeles for the step they've made. I think that is a good first step, but let me ask you some questions on. You've raised some issues that I'm wondering how they'll do. On the third page it is, you say employers must be prohibited from acting out of fear, firing capable employees because of what other employees or customers might say. How would you enforce that? How would you recommend that we enforce
Well, we have found that the most successful way is to have the law prohibiting discrimination in employment.
But how do you apply that? Well, is the employer likely to deny that that's the reason, or is there?
Well, it is now illegal in the City of Los Angeles to fire someone on the basis of having AIDS, an AIDS-related condition, or being in a high-risk group of someone who has AIDS. There are two remedies available. The person who's being discriminated against either has a cause of action for damages, court costs, and legal fees against the employer, or in the most significant remedy, the city attorney has the power to go in on their behalf for injunctive relief, and we have found that just by calling the parties together, we have avoided people being fired. And that relates strongly to the issue of medical costs, because most of the people who are being threatened with the loss of their jobs are capable of doing good work for a long time. And if they stay on the workforce and become gainfully employed, they inherently lower the cost of their treatment than when they're thrown out, not only losing their insurance, but not being able to be employed.
What happens if a man or woman is fired for reasons other than that? Could they use the fact that they may have AIDS or think they might have AIDS as a defense? Could they accuse the employer wrongly of dismissing them?
The burden of proof is on the person who's alleging discrimination.
So you'd have to prove that.
That's right.
Okay, on the next question, you say insurers should not be permitted to screen on lifestyle, or they should not potentially deny coverage on the basis of HTLV-3 antibody testing. How could you force the insurance companies not to use this information?
Well, right now in California, it's against the law to use HTLV-3 antibody testing for insurability purposes. It's likewise illegal to go into lifestyle screening questions for insurability purposes. And that law, and by the way, and your question to one of the previous panelists as to whether there was activity in California to overturn that law, the answer is very clearly yes. And I read a statement from the American Council of Life Insurance representative saying that they will do everything in their, the quote, the industry will use its substantial lobbying power to try to overturn the California law that forbids insurers from demanding the AIDS blood test. And the...
I was not, incidentally, I was not satisfied with their answer. It didn't seem as though they wanted to admit that they had any interest in that law.
In fact, they are very definitely trying to use all of their muscle, and you know that muscle in the state legislature is strong. And the Association of California Insurance Companies also say that if they can't, they will seek lifestyle screening. So both of those issues have been raised in California. We have prohibited it by law to this point.
Now, is this, you say this is a Los Angeles law, or is it apply to the whole state of California?
The the law on use of HTLV-3 testing is statewide. The anti-discrimination law that I referred to is City of Los Angeles.
Is there any attempt to get that anti-discrimination extended to the entire state?
We would like to, but I don't think the politics are there that will happen, although there may well be an effort dealing with the places of employment that might succeed.
Mr. Nance, you're a CLU. Which insurance company are you with?
I'm with an independent agency in Los Angeles.
Are you affiliated with any of the agencies that were here this morning, the Council of Life Insurance?
We do business with Blue Cross, Blue Shield, and Lincoln National.
So you work with those. How do you feel about their apparent difference? They on group insurance, they don't worry about it, but on individual coverage and small groups, they do worry about it. Does that strike you as unfair to discriminate against those who are not employed by large enough groups to get the group insurance where they can get in without any problem? Does it give you any feel that that's discriminating?
Unfortunately, the very nature of insurance is discriminatory. Those who usually need it the most are denied those coverages. The purpose of insurance is to cover an unforeseen problem, and once that problem is developed, it may not be appropriate to have that individual covered if they didn't have coverage prior to. I think the AIDS issue has brought to light this problem in large numbers, but it has also been a problem that existed with cancer, heart patients, or diabetes, or many other illnesses that individuals have a tough time buying that coverage.
Insurance companies can have special group rates and special treatment of individuals. I know in the automobile insurance, Preferred Risk has a special rate. If you don't drink, you can get involved with it. You can get lower automobile insurance. There are those who give lower rates to those who don't smoke. Is it possible that an insurance company might come up with something innovative that you can get lower rates if you have a lifestyle which would be may less be not related to AIDS, or you can show that you're not involved in the possibility of getting AIDS? Is it possible they can be creative in this area?
It's a tough question.
I didn't word it terribly well, but I think you got fun.
Unless we concede the fact that insurance companies do have the right to discriminate based upon lifestyle, the answer would be no. The State Department of Insurance is a rather strong one in California, and I think that they would find that blatantly discriminatory.
Is it discriminatory in terms of health risks in terms of smoking or drinking?
No.
where you have insurance rate differentials?
Because it's not based upon lifestyle well, it's based upon lifestyle, but it's not based upon male versus female or certain age risk or whatever. And there's 20 and 30 years of history to verify that those who drink or that smoke are more likely to have
Well, but there's also medical history from a lot longer than that women live longer than men, therefore should be entitled to a lower rate. We've dismissed that. We've said that doesn't count anymore.
In California, most insurance companies still offer lower premiums to women for life insurance.
But federally, we've said that's not a good idea. At least we've tried to say that.
Some people tried, it didn't pass.
I'm sorry, would you repeat the last comment?
Chairman is correct. I know that the unisex insurance law was said, but even so, their retirement rates and so on have been actually changed to unisex policy. In other words, they're ignoring probability, life expectancy in those instances in terms of retirement and so forth. Why don't we prohibit taking any of these things into account? In other words, if you're going to throw out the probability in terms of male versus female, or black versus white, or any of these other nature, why shouldn't we say insurance companies can't discriminate because of health or because of habits or lifestyle or anything else? Should we go that far?
If we don't have a nationalized health care program or some other system to guarantee coverage to those individuals who can't get it, then I think yes, the answer has to be yes. Insurance companies are good at spreading the risk for all risks, and if that's what it's going to take to guarantee that everyone has equal access, then that's probably going to have to be the case.
I'll yield to the chairman.
Well, the gentleman's time has expired. Mr. Danemeyer?
I'd like to ask both witnesses a question on the issue of individual insurance. As I recall, when you apply for an individual health policy, you are asked such questions of, has you ever had heart disease, cancer, blood disorder, epilepsy, mental illness, and diabetes? Do you suggest we eliminate those questions?
Again, I think I'd have to answer that question in the same way. If it means that there is no other system for those people to access in order to get proper health care, then I think eventually we may come to that.
Eliminate even those questions. How about you, Mr. Wachs?
We can't deny health care to people.
How about you, Mr. Wachs? Should we eliminate those questions?
To the extent that they, first I'm wondering to the extent which they invade people's privacy. I think that a person's lifestyle may be different than their medical history. I think the questions are quite different with respect to lifestyle than medical history.
If you smoke, I suppose I think I'm not sure they ask if you smoke, maybe they do, but...
The lifestyle questions we're referring to are basically sexual of nature and other items that are normally considered a person's right of privacy.
Well, if you're not prepared to say that we should not eliminate these questions, then why do we justify prohibiting insurance companies on individual health policies from asking a question which would reveal the status of one's blood?
Because the questions don't necessarily yield the status. In terms of lifestyle questions, they certainly don't necessarily yield the status of one's blood. They yield questions about their private lives, but they don't yield status about the blood.
Well, the blood speaks for itself. It doesn't say what you've been doing, your lifestyle.
The blood test question is a different issue. The blood test question has serious problems because in identifying people who may have been exposed to the AIDS virus, it's identifying a percentage of people estimated at somewhere between 80 and 95% of the people who will never have AIDS, and they, however, become automatically stamped. The estimates are between 5 and 20%, whichever figures you want to use. I've never heard larger. 5 to 20% of the people are going to be diagnosed with AIDS. The other 80 to 95% of the people who will not immediately become stamped, they become unemployable, and they become uninsurable, and they don't have that problem. Secondly, I think that the use of an antibody test has serious repercussions. If we are going to go into the situation, science continuously develops...
Well, wait a minute, just a minute. If the person who is an applicant has heart disease, cancer, blood disorder, epilepsy, mental illness, or diabetes, it also has serious repercussions for that person, doesn't it? Why should we treat people with HTLV3 in their blood differently from a person that has heart disease, cancer, blood disorder, epilepsy, mental illness, or diabetes? What's the policy question?
You're
as to why we
treating
should
them
do that?
different when you categorically deny anybody insurance or fire them for their job.
I'm a Californian and I should know this, I guess, but when did the legislature pass this law that precludes the use of the antibody test in our state?
It was passed this year, Assemblyman Agnos' bill.
Do you know about what month it was passed?
I want to say,
March,
I want to say April or March or April. It was AB 403, and it was passed this year. I don't have the exact date.
Thank you. And and the ordinance that the city of Los Angeles adopted is also interesting to me. I'd like to just engage a little mental exercise with you, if I may. Let's substitute the word cholera for the word AIDS. And then let's postulate a situation where a person working in city of Los Angeles has cholera. Do you think the employer should have the right to discharge that employee with cholera?
If public health experts say that it's a risk, health risk to other people, the answer is yes. But the public health experts have told us that working with someone with AIDS does not transmit AIDS. That you
but
simply
there are
don't
cases, Mr. Walks, there are cases of the 14,000 AIDS cases in America today. CD says there are about 600 of them where they can't tell whether or not or how the victim got AIDS. They just don't know. The epidemiology is not clear. We have instances where two healthcare workers recently working in a hospital, not in the high-risk group, got AIDS. They were treating AIDS victims. There's a case up in Santa Clara County where an elderly person in the early 70s got AIDS. The man, I believe, and the presumption is that his wife had no sex because of their age and the bad health of the husband, and the wife came down with AIDS. So there is what you said about the conventional wisdom of the healthcare practitioners that it's not socially transmitted is a fair estimate of what they're saying, but there's still a suspicion. And on the basis of that suspicion, don't you think that an employer should have the ability to take care for their employees?
No, all of the evidence that we had presented to us by the public health experts, whether they be federal, local, or university, gave evidence to the contrary. The evidence that we had before us was that of the 14,000 some odd cases in the United States to this point, not a single case has been documented from the kind of casual contact that is prohibited by the law, such as a landlord kicking somebody out of their apartment building or working side by side with another employee. The 600 and some odd cases that you mentioned in that category are comprised of several categories which are known. Haitians, which were previously a separate group, are now lumped into that category. People who do not want to admit certain lifestyles, such as IV drug users, but whom the diagnosticians know have been doing that, account for the other. The only cases you mentioned until finally the couple of healthcare workers, until then, there hadn't been a healthcare worker. We have now, or they had been in otherwise high-risk groups. You now have two people who have through use of needles that have been injected into a person with AIDS and accidentally injected into another person. That's not what we're talking about in the workforce. Just two secretaries working side by side, or a person living in one unit of a building of 30 units in an apartment building aren't sharing needles and aren't engaging in the kind of conduct that transmits it. So that there is no evidence that it's transmitted.
Let me phrase the question this way, Mr. Walks. Since 73% of these 14,000 cases of AIDS have come from one high-risk group, male homosexuals, it strikes me that the ordinance of the city of Los Angeles, when it seeks to protect the victims of AIDS, to the extent that it pertains to male homosexuals, aren't we really struggling to raise sodomy to the level of a protected civil right?
It has nothing to do with that. It's simply saying that you don't take a person who's facing their most profound moment of loss and throw them to the dogs and treat them as lepers. There is no good reason, there is no scientific reason. You don't have to cast a moral judgment as to whether you like conduct or not. The question is whether you protect somebody's dignity and civil rights and whether you throw them out and shun them as lepers when there is no public health reason to do it.
I don't think anybody's suggesting that we throw anybody out. Persons with AIDS are going to receive the best medical care and attention that we can bring to them. We taxpayers are going to pay for it, but I think it's important that we state where we are, isn't it?
If they lose their job and are thrown, first of all, if they lose their job and are unemployable and uninsurable, they're finding it very difficult to get health care. Second of all, health care is only one of the rights that American citizens, you and I and others, enjoy. And it seems to me that a society that has gainfully employed people that are capable of working benefits from having those people remain on the job, not putting them out on the welfare rolls.
Gentleman's time has expired. The dilemma, of course, we do have is who's going to pay, and it may well be the taxpayers will end up paying a great portion of this. But let me ask you one question. If an employer is self-insured, so that he's paying for the health care of his employees, and he knows that if he has a person who is likely to get AIDS, that that's going to cause his insurance to go way high up to pay for all of his employees, is it fair to say to him that he should have to pay that increased amount, or should he be able to make a decision not to hire an employee? Mr. Nance?
What about the fear of someone who has terminal cancer or needs a bypass surgery or a heart transplant or a liver transplant? Chances are the cost of those are going to be far more significant than the cost of treating a person with AIDS. And most employers would recognize their legitimate duty to care for those people in that manner, and AIDS is no different.
Well, let me thank both of you very much for your presentation to us. I'm sorry you had to wait so long, but I think it's been very helpful to us to hear from you. Our last witness is Mr. Elmer W. Smith, Director of Eligibility Policy, Bureau of Eligibility, Reimbursement and Coverage, Healthcare Financing Administration, Department of Health and Human Services. Mr. Smith, we're pleased to have you with us, and we'd like to ask you again to, as we have others, to summarize your testimony in 5 minutes.
Fine. Thank you, Mr. Chairman. Both the Medicare and the Medicaid programs are broad-gauged health financing programs underwriting a variety of services for defined groups of people. Now, as such, they differ from many of the public health service programs that are disease-oriented or underwrite services for particular groups like maternal and child health groups. The services in the eligible groups of people are both defined by statute. Fundamentally, persons become eligible under both the Medicare and the Medicaid programs by being determined to be eligible for cash benefits. And these cash benefits can be provided under the Aid to Families with Dependent Children program, which is a federal state program, the Disability Insurance program, which is a purely federal program, or the Supplemental Security Income program, which is a federal program with state supplemental payments. The most important way that persons with AIDS can qualify for assistance with their health care needs is through the Medicaid program, since there is a 24-month waiting period for Medicare after a person has been awarded cash disability insurance benefits. Now, mandatory eligibility under the Medicaid program is conferred in a variety of ways. For children, they can qualify because their families are eligible to receive AFDC cash benefits, or because their families meet the income and resource tests of the AFDC program, and the children are under age 5, even though there may not be any parental deprivation, like absence of one of the parents. Adults in the age groups most susceptible to AIDS can obtain eligibility because they are determined to be disabled under the Supplemental Security Income program. Now, optional coverage at state discretion is also conferred on persons who qualify either because they are disabled or they can qualify as AFDC or AFDC related, even if they have more income than is permitted under the cash assistance programs. These are the so-called medically needy recipients, and 35 states have such programs. 6 of these are limited to pregnant women and children under the age of 18. The remainder of the states have comprehensive medically needy programs covering aged, blind, disabled persons, as well as children and their caretakers. Now, since 1983, the Social Security Administration has recognized AIDS as a disabling condition for purposes of cash benefits under the disability insurance and the supplemental security income programs, and also as a basis for presumptive disability awards. That basically means that a person can essentially be granted cash benefit status immediately without waiting for the processing of their application on the grounds that they are presumed to be disabled. And it allows people to get cash benefits earlier than they otherwise would. Once the Social Security Administration has defined somebody as disabled, this SSI definition essentially controls disability determinations in most of the states for Medicaid purposes. 36 states apply exactly the same definition for Medicaid purposes as does the Supplemental Security Income Program. And of the remaining 14, most of the remaining state plans use essentially the same definition as that of the Supplemental Security Income Program. Most services needed by AIDS patients are required to be covered by states under their Medicaid plans. That is, they are the so-called mandatory services. These include inpatient hospital services, outpatient hospital services, lab and x-ray services, physician services, skilled nursing facility services, and for children, the early periodic screening, diagnostic, and testing services. Unfortunately, Medicare and Medicaid data are not kept in such a way that AIDS cases can be separately identified. Using very anecdotal and fragmentary information, we estimate that the Medicare program serves about 1% of the currently diagnosed AIDS cases, and the Medicaid program serves about 40% of currently diagnosed AIDS cases. As indicated in my statement, a small number of states have voluntarily agreed to collect information about AIDS cases, and HCFA is also participating with the states and the Center for Disease Control in a research effort to improve our information efforts by using tape-to-tape data from 5 states. Furthermore, the Department of Health and Human Services is asking $196 million in the 1986 budget for research and other AIDS-related activities. I'll be happy to try to answer any questions you may have.
Thank you very much, Mr. Smith. People who are diagnosed with AIDS are considered disabled.
That's right.
And therefore, if they're poor enough, they can go on Medicaid to pay for their health care coverage. Is that right?
That's right. Or even if they don't qualify by being poor enough, if they have substantial expenses and they incur substantial expenses and spend their income down, they can become eligible for Medicaid, even though their total income may be higher than that required to qualify for the cash assistance program.
So they're either poor enough to qualify or they become poor enough by spending away their assets in order to qualify.
Their income, right.
And then they're covered by Medicaid, which is the poverty health care program, if they have AIDS. Now, what if they have AIDS-related complex?
AIDS-related complex is not considered essentially a qualifying condition for disability insurance or for the Supplemental Security Income Program. If a person had some condition which fell under the medical criteria for disability insurance or supplemental security income per se, then they could qualify for cash benefits and become qualified for Medicaid. But AIDS-related complex as such is not considered a qualifying disability.
So they're not considered disabled under the Medicaid law. Therefore, even though they have AIDS-related complex, which requires medical treatment, they don't have coverage for that.
That's right.
Okay. Now, what about people who are tested, find that in a test of their blood, they have a positive HTLV3 test, which indicates they've been exposed to the virus? Does that qualify them for Medicaid?
No, it does not.
Now, if people who went through some screening process and found that they had a positive HTLV3 test, get thrown out of their insurance plan, Medicaid won't cover them for other problems.
No, the statute is set up in such a way that Medicaid covers people who are aged or who are in families with dependent children or who are blind or disabled. And so a positive test per se does not mean that you are disabled.
One side of this whole question about insurance is who will pay for the AIDS patient's medical care. I guess another side of all this is if they use a blood screening test to deny people eligibility for insurance, a lot of those people, in fact, most of those people will never get AIDS. They may come down with other illnesses, and they may not get in coverage under private insurance. Would they be eligible for public insurance?
No, you cannot become eligible for one of the health care financing programs merely because you can't find private health insurance coverage.
So they may just be out of luck.
They may have to use their own resources. They may have to rely on, in terms of hospitalization, on the Hill-Burton free care commitment. They may have to rely on other community resources. That's right.
If it's true that there are 500,000 to 1 million people that would have a positive result on this blood test, and none of them could get health insurance, and only a small percentage, 10, 15, 20% will ever get AIDS, we're talking about, I haven't done the mathematical calculations, but large numbers of people in our society who will never get AIDS and will have no coverage for their health care needs and will not be able to get any coverage for their health care needs.
Well, I think earlier witnesses before this committee indicated that in most cases there is no intent to apply the screening test to group health policies. And many people will, of course, be covered under the group health policies.
But most employers are covered under the individual policies. Most employees get their benefits from their employment, and therefore those who work for some of the largest corporations in this country will really be out of luck if there's this widespread screening. I just pointed out as the other side of this problem that we've been examining today. Mr. Nielsen?
Yes, Mr. Smith. Has there been a large increase in the AIDS victims getting out on the SSI DI roll since February? What has the increase been?
The statistics that I have indicate that in terms of cases filed, that in 1983, and these are not broken down between disability insurance and supplemental security income, but there were 425 cases filed with the Social Security Administration. In 1984, there was 1,223, and in 1985, 2,800.
So that's about 80% increase then, just since February. Okay, are any Medicaid demonstration projects treating AIDS patients at the present time?
I am not aware of any demonstration projects per se, no.
Why not?
They are receiving benefits basically under the ongoing structure of the Medicaid program, which offers a very broad range of benefits, particularly in those states in which most of the AIDS cases are found at the present time.
Why has the Department of Health and Human Services not had some demonstration projects?
Well, I guess because there wasn't felt to be a need.
The Secretary on several occasions said it's the #1 need right now, #1 health problem.
It's a #1 health problem, that's right, and a lot of money is going into research, and a lot of money is going into services. But the need for specific demonstration projects, I don't think, has been shown.
Have there been any pending applications for demonstration projects?
I would have to provide that for the record, sir. I don't know out of my personal knowledge.
Of course, you would demonstrate, you would get the need if you start applying for demonstration projects, that would then clarify the need, what you're saying. The increased incidence of AIDS required HICFA to re-estimate the projected costs on Medicare for this year, the next year's budget?
For Medicare?
Mm-hmm.
No, there's such a small proportion of AIDS persons on the Medicare rolls that would not affect the cost.
You haven't had to recalculate Medicare. What about Medicaid? Have you had to recalculate that one?
There are still a relatively small number of persons on the roll in terms of the 21 million persons that are eligible for Medicaid that no, that would not be a significant factor either.
Well, if it's no significant factor in Medicare or Medicaid and you don't have any demonstration projects need for those, how is it it's called the #1 health problem then?
I think it's a #1 health problem because it is one of the leading causes of death for a population cohort which is between the ages of 21 and 34 or 21 and 40. I've forgotten the exact age cohort.
I seem to recall a former administration had a great deal of talking about how important flu epidemic was going to be. We went to a great deal of effort to getting geared up for a flu epidemic, and a lot of money and time was spent on that, a lot of fanfare, and yet it didn't occur. Isn't this a more real problem than the flu virus we were worried about several years ago?
I'm not in a position to evaluate that, sir. I'm sorry.
I'm just wondering why we're just talking about rhetoric and not action in this case. It seems to me that the Secretary Heckler, and I agree with her statement, has made this one of her goals. Has she been precluded from doing this? Has someone talked her out of giving this a priority, or is there just a feeling that it's a great thing to talk about, but it's not going to affect our budget, it's not going to affect Medicare, it's not going to affect Medicaid, we don't have any demonstration projects? I don't want to be unfair to the Secretary or to you.
First, I don't think there's a complete causal relationship as to whether there are demonstration projects under Medicaid and Medicare and whether it's a high priority.
Let me rephrase the question. If it is a high priority, what are you doing, and what suggestions would you make other than the ones that I've mentioned here? What do you intend to do about the AIDS situation from a department standpoint?
I can only speak from the Medicare and the Medicaid programs which support services to persons who have AIDS. I can point out to you that the department is spending already about $132 million in research and epidemiological studies through the CDC and activities of the Food and Drug Administration, for example.
Let me ask a question on that. We had witnesses earlier today say that the records have to be confidential, and we can't get that information. The insurance companies complained that they could not have access to that information, had no statistical basis for figuring their insurance rates. Do you agree that these things should be confidential because the personal nature of the data?
That's outside my area of expertise. I'll be glad to try to supply a statement from the department for the record.
Would you please? Thank you, Mr. Chairman.
Right.
Thank you very much, Mr. Nielsen. Let me just ask you one last question, Mr. Smith. If costs are absorbed by hospitals as charity care, because there's no one to pay the bill, won't that in turn raise hospital costs, and won't that in turn also raise insurance costs?
Just speaking from my personal experience, I would have to say yes, I would think that it would. It would get dealt back into the payment system by being spread over private payers. It will get dealt back into insurance costs. It will get dealt back in some ways in terms of bad debt allowances, which may have to be met by state and local tax levies.
So there's no way to avoid it. This AIDS epidemic is going to be a very expensive proposition for our whole healthcare system. It's going to mean a whopping bill, and some group or other may try to shift it off to someone else, but we're faced with one final conclusion. Somebody is going to have to pay the bill.
Correct.
Well, I thank you very much. I thank all the witnesses. That ends our hearing for today.
Been watching a hearing before the House Subcommittee on Health and the Environment, chaired by California Congressman Henry Waxman. If you have any questions about this hearing, you can contact the subcommittee at 2415 Rayburn Building, Washington, D.C. 20515. Coming up next, El Salvador's President Jose Napoleon Duarte addresses a special breakfast at the National Press Club on the problem of terrorism. Accompanying the leader is his daughter, Inez Guadalupe Duarte, who has been recently released following her kidnapping more than 2 months ago.
Patients often display symptoms of AIDS in minor mouth and gum conditions. As the killer disease becomes increasingly widespread, television becomes a natural tool to publicize the plight of its victims. And that is causing some controversy, as Sandy Kenyon reports.
I can't taste your sauce. I got AIDS. I'm dying. I'm dead.
Time was you couldn't even mention the disease on the air. Now it's the subject of an upcoming TV movie and episodes of 2 series. You might expect AIDS to be discussed on cable television's Brothers, the first series with an openly gay main character. But AIDS also crops up this weekend on CBS's Trapper John, MD.
Point is, Catherine, it is not a homosexual disease. It can affect anyone.
The issue remains a touchy one for the networks, as the writers of the TV movie An Early Frost discovered. Dan Lipman and Ron Cowan had to rewrite their script 14 times.
We had some battles with the censors that were difficult.
One battle in particular comes to mind. NBC did not want the grandmother, played by Sylvia Sidney, to kiss her grandson who has AIDS, played by Aidan Quinn.
No, Gran.
Michael, it's a disease, not a disgrace.
In the end, the writers prevailed after citing medical evidence. But scenes showing Michael's homosexual lifestyle weren't filmed because the network didn't want to appear to be condoning it. For all the new talk of AIDS on television, one AIDS patient is not impressed, though Stephen Stucker is himself in show business.
I've lost 40 friends plus in 6 years. I think it's very difficult to portray something as complex as this in an hour-and-a-half to 2-hour film or a series of half-hour shows.
Nevertheless, the people behind these programs still believe they are performing a service.
For one thing, it brings it into your living room through people that you're familiar with, and it takes away some of that hysteria.
Reports the pair were in Canada recently pressing for peace.
A remarkable sight, sharing the same platform, sharing the same cause, sharing the same hymn, a Russian and an American. The occasion was the convocation at Queen's University, where this unlikely pair received honorary degrees for their work for peace. Earlier, they met reporters. This is Yevgeny Chazov, a member of the Soviet government, a deputy minister of public health in his country, a doctor. And this is Bernard Lowen from Harvard, one of the world's leading heart specialists, also a doctor. Together, they founded the organization International Physicians for the Prevention of Nuclear War, winner of this year's Nobel Peace Prize. Avoiding nuclear war, they say, is the greatest issue in the world.
That both Mr. Gorbachev and President Reagan have a unique opportunity now to give a Nobel Prize to all of humankind by providing them with the security of survival for themselves and their children.
Chazov's point, whatever else may divide people, avoiding war does not.
No matter what political views we hold, what religion we profess, or what nationality we belong to, we are united by our common aspiration to protect life on Earth.
These two doctors came here from different planets politically, but they came united in at least one cause. They both see themselves as propagandists, and their propaganda is peace.
Next on Headline News, another day of experiments in space, and we're keeping an eye on the shuttle crew for you.
Naturally in the foods we eat, from spinach to steak.
Well, it turns out that food contains many substances which are, if you test them, I mean, it's the same kinds of tests that artificial substances are tested for their cancer hazard. For example, it turns out they're also carcinogens, and that they seem to be just as hazardous as the artificial substances, for example, the food additives or the pesticide residues that may be left. And yet, the natural substances are present there in much larger amounts.
For example, green leafy vegetables contain nitrites, which turn into carcinogenic nitrosamines in the body. Fermented foods such as bread, sake, and beer contain urethane. Charbroiling steak or burning toast creates benzoate pyrene, And moldy peanuts may be contaminated with aflatoxin, an extremely potent carcinogen.
Now you might ask why are they so ubiquitous, and the answer is that plants are trying to protect themselves against grazing animals and birds and worms and nematodes and insects, and so they naturally have a lot of these substances as kind of a natural pesticide.
Dr. Havender says he doesn't mean to alarm the public with warnings that there's nothing safe to eat, but wants to help put food risks, natural and man-made, into perspective.
And right now it looks as though the cancer risk from the natural substances present in food are much larger than the cancer risks from the substances that get in as a result of food processing.
Fortunately, many of the foods that contain natural carcinogens also offer substances that seem to prevent cancer, such as fiber, vitamin C, vitamin A, and carotene. So the best advice is to enjoy a variety of foods and eat all foods in moderation. To get the most enjoyment, Bert Wolf suggests a pinch of herbs and spices. So here's some seasoned advice.
Professional chefs and good cooks have always known how important the right seasoning is to a recipe. What would French fries be without salt, or pizza without oregano, or Chinese food short of its soy sauce? The foods of different countries and regions have their own special spices and herbs. The Greeks are waist-deep in their garlic. The Jamaicans are in love with their peppers. The Norwegians have made their darling dill. One thing that all these cooks are trying to do is avoid a bland dish. But there are a number of factors beyond the chef's control that can cause a dish to taste bland. 3 common ingredients can actually dull your taste buds.